I'd like to call the meeting to order. This is the Oregon Health Policy Board meeting, June 5th, 2018. So we have a quite busy day today. We are both extending our board meeting for a couple hours, so our intent is to go until 2 o'clock. And we get to hear from each of our different teams that have been working on the CCO 2.0 policy options for our consideration. I'll talk a little bit more about how we're going to do that a bit later, although I'll throw a lot of that program over to Jeremy and the team to walk us through all those different options. But before we do that, first we should consider our minutes from our last meeting, which are in, I have to find mine. Oh, there they are. Is there a motion to accept the minutes from last meeting?
So moved.
Great. Is there a second? Great. Any discussion about the minutes from our last meeting?
I just want to thank the staff again for summarizing the reports for the subcommittees. I think it's really helpful to see.
Yeah. Agreed. Thank you. Any other discussion points? Okay, all those in favor of accepting the minutes as written for the May 1st meeting, say aye.
Aye.
Anyone opposed, say no. Great, the minutes have passed. We've exercised our action muscles. Second thing I wanted to do is just, again, take a quick look at our long-range calendar, or our annual calendar, I should say. Thank you. So, flipping to the second page, you'll see we're in our extended meeting. At our next meeting, we anticipate hearing about an update on the high-cost drugs work, and then continuing to explore our CCO policy options and recommendations. Flipping the page in August, you'll see through October, a lot of our focus, of course, is on CCO 2.0, or through September, I should say, but a couple of other key updates that we'll get there as well. And then again, working on an out-of-area meeting in Hood River on October 2nd.
I will be a remote attender on July 10th.
Okay, good to know. Attending, but by phone. Any other thoughts about the calendar? Great. Hopefully, if possible, it'd be great to lock in that October visit soon, so people can get on their calendars. All right. So before we jump into the rest of our meeting, we have public testimony. We have 4 people who have signed up today for to provide public testimony. As a reminder, with the public testimony, we ask that you keep your comments to under 3 minutes. I'll give you a reminder, or I'll give you a signal when you have about a minute left. And as you come up, I'll call you up, but then as you begin, if you can just restate your name and your organization. And then because it's public testimony, for the most part, the board won't directly engage in discussion, but we really appreciate you coming and providing testimony, and that it does go into the record. So with that, I'll call up the first 3 individuals, or I'll do 2 since there's 4, 2 and 2. First 2 are Kevin Fitz and John Ames. Come on up, and John and Kevin, you can take your turn. You can decide who goes first. John, you're there. Looks like you've got the catbird seat.
Great.
Hi, no, go first.
Okay.
Go first.
Right.
I'm just getting my wind.
Well, good morning. Thank you for allowing us to come and talk to you today. My name is Jonathan Eames. I'm with Eames Consulting, but I'm here on behalf of OPRA, which is a mouthful. It's the Oregon Prevention, Education, and Recovery Association. They're the statewide association representing both for-profit and not-for-profit alcohol and drug treatment facilities, both inpatient and outpatient. And we submitted a letter to you regarding CCO 2.0 and your work there, and wanted to emphasize it today a little bit with testimony. First of all, we applaud your work, and we know how difficult this is. I know one of the governor's 4 main focus areas is behavioral health and making progress on behavioral health, and that's great to say, but hard to do. And trying to figure out how to encourage our state to not only better invest, but also think about behavioral health differently and build a world-class behavioral health system is going to be daunting. We have in our neck of the woods, in our provider community, the most daunting challenge is our workforce. That comprises roughly 90% of the budget that treatment providers have, and because of the tremendously high turnover rates, sometimes nearing 50%, it's incredibly difficult to retain and hire a qualified workforce. And what that does is it not only endangers your ability to keep the doors open, but it also endangers your ability to provide quality care. So how do we get there? How do we change the dynamic? How do we change the framework of how not only the state funds behavioral health, but also CCOs, how they fund behavioral health? Well, I think one of the original visions, and I know a couple of folks definitely in the crowd and then also people here worked on that original vision back in 2010 when we were talking about this. And one of the principal thrusts was, hey, how do we get investment from the effects of a healthcare problem to preventing that healthcare problem in the first place? And especially with addiction, as you all well know, there are so many downstream effects from that addiction. If we could upstream invest in addiction and addiction treatment, we're going to prevent a lot more costlier health where people get their health care later on. And so what we're asking is a couple of things. First of all, let's focus on the structural barriers to providing these incentives. What are the things that CCOs can't do right now, and how do we remove those barriers to further invest and focus on behavioral health? And second, I think if we can look at the Metrics and Scoring Committee and the work that the Metrics and Scoring Committee does to encourage those incentives for CCOs, I think if we can find some robust metrics that actually tie back to some meaningful and substantive outcomes, that would be great. The last thing I'd like to say is that we also understand the responsibility of providers in this. So it's not just, give us more and we'll go on our merry way. We know that we have outcomes and we have responsibilities to further health and better health in our state. And so we stand ready to step up to that and make those investments in collecting, gathering the data, and then acting on that data to improve health. But it's a chicken and egg. We can't expect great outcomes if we're not focusing from the front end and investment in behavioral health. So encourage you to read the letter. If you have any questions, feel free to contact us. But thank you for the time and good luck. It's going to be a lot of work.
Thanks, John.
Thank you.
Mr. Fitz?
I missed the letter in our packet.
I don't think it was included. John, did you submit it to the?
We did,
This morning?
but
We'll
I
get it,
can-
we'll get it right.
Okay.
Okay. Okay.
Good morning. My name is Kevin Fitz. I'm with the Oregon Mental Health Association. Thank you, Chair and Council, for letting me talk this morning. I just want to do a 15-second survey. How many of you on the board have ever been to a department store called IKEA? Ever been to IKEA? People probably know about IKEA. I was looking over the CCO 2.0 organizational charts, and I wondered whether the person who actually designed some of the IKEA walkthroughs also had a knack for designing org charts, because they kind of they had a similar a structure to them. So that said, and I know it's a large agency, but that said, looking at this, I have one area that I'm particularly interested in, and that is consumer inclusion and consumer voice. And I think I sound like a broken record. I say it over and over again. We have 1 million roughly 1 million Medicaid recipients, somewhere between 150, 200,000 behavioral health recipients. We find that this system, the CCO structure, OHA, we would like them to do, continuing to do a better job of engaging the recipient voice in policy and services discussion at a management or consequential levels. So to that end, you have by state statute a thing called the Oregon Consumer Advisory Council. Currently, and this is getting in the weeds, that is staffed, that is overseen by a staff who's in your adult services manager. A conflict of interest is too strong a word, but I would like to see in your reorganization, when you bring in your new behavioral health director and a new policy director, is to take the staffing that is staffing your consumer advisory council and either move those laterally into policy so there isn't because sometimes services has a conflict of interest with consumer voice. And they're both valid to be heard, but we sometimes feel like in the services silo, it might make sense to move the policy and the consumer voice into a place where it doesn't feel intimidated by the provider community and all the work that folks like he and his colleagues do. So I can point this out more to Jeremy and Mike Morris, but that's my little tweak, is to say, look at what you're doing for behavior. Do you have a question?
Yeah, funny.
So that particular issue under behavioral health, where is your consumer voice, your consumer office, and your consumer advisory council? How do they connect into your new behavioral health reorg? And I will follow up with Mike Morris and Jeremy to make that more clear. So I hope, is that clear? Is there do I have any questions? Or am I out of time, Chair?
Not yet, but we appreciate you yielding the rest of your time.
Yes,
Mr.
yes, good.
Thanks, both of you. Appreciate it. So next two on the list for public comment, Bruce Thompson and Silas Halloran Steiner. Come on up. Price is right. Doesn't matter. You can choose whatever chair you like, and you can speak in whatever order you choose.
Nice to meet you. Go ahead. Yeah, I think they called your name first.
Good morning. Thanks for this opportunity. I am Bruce Thompson. I'm a graduate of Oregon Health Sciences University School of Medicine and the Family Medicine residency program there. And I presently live in Corvallis. I'm presently a retired family physician. While I was at OHSU, I studied under Professor Dr. Harold Osterud, who is an icon of public health at the university at the time. So, and I would be remiss if I didn't mention, since this is a public a meeting about health, that the city of Corvallis was the first city in Oregon to have regulated tobacco exposure in restaurants, bars, and workplaces. And also, at the same time, the second municipality in the nation to do that. So I was part of that effort when I returned to Corvallis after medical school. So I'm here today to highlight the importance and the need for commensurate partnerships between public health and CCOs in order to achieve the goals of the triple aim. So I mentioned I'm retired. I'm 90% retired and 10% remain active in public health. For years, public health has reduced health inequities and addressed social determinants of health in the communities around Oregon. Been doing it for years. And the Corvallis regulation on tobacco exposure is an example of that effort. So assessing community health needs is a core function and a capability of public health already developed. So what is the need to require? This is a question I would have, and I don't expect an answer. I guess just to pose the question, what is the need to require CCOs to duplicate a community health assessment if one of this already been done by the local public health authority? And furthermore, what is the point in having a CCO community health improvement plan that is not congruent with a community-developed community health improvement plan? So local public health authorities would benefit from appropriate compensation for the work they are doing to advance the goals of better care for more people in the state of Oregon. Public health does its prevention work in local parks, school gymnasiums, city council meetings, and in people's homes. It's not your typical doctor's office, but it is where people live and work. An excellent example of how local public health improves access and equity. Alternative payment methods is a pathway to strengthening this essential work in social determinants and equity. The Oregon Health Policy Board has the responsibility to help build bridges to strengthen and enhance partnerships with local public health authorities. CCO provides an opportunity to enlist the expertise of public health. Some of our local public health authorities are nationally certified and accredited to do this work towards meeting the goals of the Triple Aim. Thank you very much for your time and this opportunity to give you my perspective.
Thank you, Dr. Thompson. Mr. Halloran Steiner, you got 3 minutes, and at 1 minute left, I'm going to give you one of these.
Excellent. Thank you, Chair. Good morning. My name is Silas Halloran-Steiner. I am the president of the Association of Oregon Community Mental Health Programs, representing your community mental health system, publicly funded for all populations across the state, often thought about as our safety net system of care and services. One of the things I wanted to do was thank you for your time, effort, energy, and tell you that the AOCMHP is here willing to be party and an allied provider network for CCO 2.0, and certainly have been really involved in the creation of CCOs and are integrated into CCOs throughout the state. And it looks different across the state, as you know. But we really want to be part of the solutions. We know that this is a huge need for our community, broadly speaking, and that population health, to get at the core of population health, we need to think and behave differently with regards to the partnerships with local public health authorities and local mental health authorities. So we touch all payers, all populations, and have a connection to county boards of commissioners and one tribal entity. Specifically to CCO recommendations, we have a paper, 2 pages in front of you that are 5 recommendations. One of them is about CCOs, and one of them is about population health initiatives that are more broad for behavioral health. I don't want to hit everything, but I do want to call out a couple big ones. So number one, we need to get at the carve-out for the Oregon State Hospital population. And there is a way to do that. It is a math exercise, and it will drive better health for our communities in the state of Oregon. So if we can put communities, CCOs, at risk for that patient population and no longer allow them to go 100% state taxpayer funded to the state hospital for any length of time, that carve-out, we need to solve for that. And there is a way to do that. There's a work group that is providing some information. Hopefully we'll have some models, for you to consider, for whomever to consider at the health authority. We do believe in transformation. We think the health authority can do more to regulate and encourage and enforce the existing laws that exist. One of them being the laws that really require the local public health authorities and local mental health authorities to have contracts and agreements in place for the services. I also want to touch on some of the cross-sector work that can happen more effectively in CCO 2.0, and that really speaks to the United States Department of Justice settlement and some of the cross-system like DHS child welfare and public safety and other major public investments that if we can align those goals together, we're going to be stronger at the local level. We do believe in prevention. We absolutely think that we can make more investments into prevention. There are evidence-based practices that are working that we can really select from to make sure that lifespan we have a prevention and health promotion system in place instead of a reactive crisis-driven or a sick care system. And we are ready to provide more information for your consideration around those issues as well. So to conclude, because I want to be careful with your time, you have a big day ahead of you, please keep the decisions at the local level. If we can do one thing that we did right with CCO creation. It was to put the local healthcare and education and ecosystems for people at the local level and to create community models that worked. And we believe we can do that in CCO 2.0 if you stay true to that value.
Great. Thank you very much. Thank you both for your comments and for your written testimony as well and recommendations.
I can submit a written form of my testimony as well, if that.
Great.
if that
Yeah,
would be helpful.
absolutely.
Thank you.
Much appreciated. Just as a reminder for folks, we'll be continuing to do this public testimony portion of the agenda, or of our meetings, I should say, at the beginning of the agenda. So if people, as we move through our meetings, are interested in providing public testimony, you can let our office know ahead of time, or you can come at the beginning of the meeting and get on the list ahead of time is always appreciated, because then we can plan for it as well. With that, we'll move on to our next agenda item, which is our OHA report around reorganization. And Jeremy Vandehay is going to take us away.
Great, thanks, Zeke. So apologize, Pat wasn't able to be here. He's at a opioid summit, tribal opioid summit at Warm Springs today. So wanted to report back on the reorg changes that he proposed last month and are asking for your approval at a functional level. Pat outlined a number of changes last month, including reestablishing a Medicaid and behavioral health unit within the health systems division, with a Medicaid director clearly over the Medicaid unit, and a behavioral health director clearly over the behavioral health unit. The functional chart that you have today functionally doesn't look different than what he proposed last month. We've done a ton of outreach with staff, including survey, office hours, tons of conversations, and has made a few changes, which I'll outline. But in terms of that high-level structure, still proposing the same changes of reestablishing that behavioral health and Medicaid unit within the health systems division. The two changes that you'll see on the functional org chart are actually both in my division, the Health Policy and Analytics division, and that's changing the office that Dana Harganani oversees, which was previously called the Clinical Services Improvement Unit to Delivery System Innovation. It's the same body of work, but reflecting that the work that she oversees goes beyond just what's within the clinic walls, and clearly calling out the transformation centers within the Health Policy Analytics division, which is feedback we received from stakeholders and staff to really be clear about where the transformation center lives within the agency. A couple of the other changes from last month that Pat's made based on feedback are we're adding a deputy director position within behavioral health. So both Medicaid and behavioral health will have a director and a deputy director. Mike Morris is agreed to serve as the interim behavioral health director while we conduct that recruitment, and then we'll slide into the deputy position similar to David Simnett. He's right now serving the interim, and then we'll slide into deputy. We've also realigned the policy teams within both of those units to report to the deputies, and are hoping that will provide a nice way to have collaboration between Medicaid, behavioral health, and the health policy and analytics by having the policy units elevated and reporting directly to the deputy. And then finally, he proposed in May establishing a substance use specific position, and he's tweaking the name, still has that, but tweaking the name to addictions recovery and prevention to align with feedback that we received from stakeholders. So happy to answer any other questions. I'll just also note that actually two more things. One, to Kevin's point, I think Pat mentioned this in May, that he's looking to reestablish and build out the ombuds role within the agency. We only currently have one, and he's looking to add some more. He was hoping to ask for approval from the emergency board in May, but because of the special session, the emergency board didn't end up meeting. But he's got some other backup plans to be able to start to build that out until he can go get the formal approval from the legislature. But has the idea is to bring more of that consumer voice and to bring it into the director's office, so we've got a good line of sight into what we're hearing. And then the second piece is wholly expecting that none of this is set in stone forever, that once a behavioral health director is hired and a Medicaid director is hired, and we're starting those recruitments right now, that there may be tweaks once they get in there and start looking under the hood in terms of how things are actually organized within each of those units.
I'm sorry, not having a good sense of what had gone previously. So where was the Transformation Center?
So the Transformation Center's been in the Health Policy and Analytics Division, and it's still staying there. And the reasoning is that, we stood up the Transformation Center as part of a big SIM grant that we received from the federal government, and part of its role was to provide technical assistance to CCOs, but to also help spread the CCO model beyond just Medicaid, and so that's why we're keeping it in the Health Policy and Analytics Division.
Other questions? So, as the Health Policy Board, one of the responsibilities that we have at our discretion is the reorganization of the department. In my tenure, this is the first time that a director has actually brought the reorganization to this body as more than just an informational item, but actually looking for input and feedback and ultimately for some sort of affirmation. So I think what we're looking for at this point is a motion to, in effect, accept the reorganization as it's designed by or outlined by the director, and then we can have some discussion if we have a motion and a second for that.
I appreciate Pat's transparency in bringing this forward to the board, and also his constructive reorganization of OHA, as well as his engagement with the traveling groups to receive public input. So I'm very much in favor of this.
Is that
I make a motion to approve.
great? Is there a second? Second. Great. It's been moved and seconded that we would approve the reorganization as presented to us by the director and by Jeremy. Is there any other discussion on the item?
Just in general, I think I would find it useful at some point to just have some idea of where are consumers, patients. I know there can be some confusion about which are which, throughout OHA. And at what points and where do they have a chance to provide you all input?
Yep, happy to go over that with you. It'll be a long conversation. I think we have about
Yeah, I bet.
250 committees throughout the organization, but happy to go over that with you.
I think it's a great idea. I mean, I think we should do it after September, given what we've got in
Yeah.
front of us. But I do think that both in the interest of both the governor and Pat have been really clear about their interest in increased transparency, and I think getting a real clear sense of the relationship between the public and the department or the authority itself would be great. I also just want to appreciate you acknowledging, but I think it's a pretty big deal that we've got a director who's willing to kind of bring this level of engagement around the department structure. So not just to bring it and say, here's what I'm doing, but then literally to say, and I'm looking for input and feedback on that, to take that input and feedback from multiple stakeholders and then to show where that feedback actually was incorporated into the design. So from my perspective, I don't know many directors of large public systems who are willing to put themselves in that space. So I just really appreciate that level of transparency, and I think it reflects both the value that Director Allen brings to this, but also an affirmation of the governor's hiring him in the first place. So really appreciate that, and it's a really complicated beast. And that did not change with the reorganization. So I also appreciate that there is opportunity for us, particularly as some of these new positions come online, to continue to look at and to pay attention to the degree to which the system really reflects the kind of both transparency and then effectiveness and efficiency that I think we're all looking for together. So feels like this is a really good opening to that continued relationship between the board and the director around the department. So much appreciated, and I'm excited to be at this position, in this position. Barring any additional discussion, I will entertain a vote. So all those in favor of the motion to accept the reorganization as it is currently laid out, please say aye.
Aye.
Hearing no opposition, although I should check in. Do we, Felisa, are you on the phone? I didn't think so. Okay. Great. Motion passes. Thank you, Jeremy, for pinch hitting. You did well. And I'm gonna turn much of the rest of the meeting over to Jeremy and the team, although there's gonna be a lot of opportunity for engagement. I do wanna, so we're gonna move into kind of full-on CCO 2.0. And given that we've got a larger audience than I've seen in the 4.5 years I've been here, I think they were interested in the reorg, Jeremy, but I think they're really interested
They
in
haven't
CCO
left yet, though,
2.0.
so.
That's true. So anyway, there's a few seats that are empty in the front, if people want to get comfortable. So, as we think about the process that we're undergoing here, which is all about, in the immediate, getting to a set of recommendations in September that we as a board can affirm and support. And as a reminder, those recommendations are really about the future of the CCO system or the coordinated care model. And I would say the relationship between the health authority and the coordinated care organizations in implementing that model. And so as we look at it, and as I think we've thought about it in September, we really see a set of recommendations from this body to the director and to the leadership team at OHA about that would be incorporated into the procurement and contracting process, a set of recommendations that would be incorporated into kind of an ongoing management system between the CCOs and the health authority, and then potentially a set of recommendations that require action from other stakeholders, including the legislature and the governor. And then there's kind of, I think, probably a bucket of things that require quite a bit more action or work, including things that we might want to include in subsequent waivers and or negotiations with the federal government. So a few different buckets of policies that are all then arranged by content in the four, what we've been calling buckets that the governor has asked us to pay particular attention to: behavioral health, social determinants of health and health equity, cost, and then values-based payments. And so today we're going to hear about a set of policy options in each of those different buckets. The idea with today's meeting is, one, just to kind of get out there on the table all of the options that the staff is currently recommending to us for consideration. That doesn't mean that all of those options will be recommended or that we'll take action on them, but that they kind of define the arena that we're currently looking at as we think about those four issues. We're not going to take action on those today. We're not going to say, I like this one. I mean, we can, but we're not going to formalize kind of, we like these, we don't like these. But rather, the process at this point is to get those out and then to identify what additional information we really feel like is important, and how the staff can gather that information to come back to us in the next subsequent couple of months, so that we can really hone in on what happens in September. So I say that partly to say there may be or may not be the level of detail and or depth that people are going to, on the board, are going to want to see in our final policy considerations. That's okay. That's where it's supposed to be at this point. We want to identify where we think that we want to be able to define that depth. So that is part of the discussion today. Worth hearing kind of additional information. I think also worth identifying whether or not the options that we're considering actually look like they'll provide some either resolution or some additional movement on the key questions that we initially started with. So that'll be part of the conversation. We'll kind of go through each bucket, hear from staff, and then get some opportunity to reflect in each of those buckets. And then we also have an opportunity at the very end to do kind of more reflection, both in terms of what do we want to see in the report that the staff will be coming back with additional information, but also just making sure we're on the right path. So that's a lot of what we're going to do today. It'll be good back and forth. I think fairly informal discussion is good, and I I think with that, I'll let you fill in any of the holes.
No, I think you
that I
did,
missed.
you did a great job. I think, just to reiterate what Zeke said, I mean, I think today we really want to have an opportunity for you to ask questions, get clarification. We talked about initially today being a straw proposal, but we aren't there yet. We really feel like we needed time to vet the ideas with you that have been percolating. The next step really is going to be figuring out how do we help support you in prioritizing and narrowing those ideas. So what we've been talking about is a feasibility and impact assessment next, where we start to analyze how different are these from what's currently in contract, as an example, or and how big of an impact do we think they're going to have on the triple aims. So at the end of the day, we really want to spend some time with you after you've heard everything that's out there, thinking about what's the type of criteria and things that you would like to see in that analysis that staff will do throughout the month to really help you start to prioritize in July, which of the various options starts to move forward. So. Just to fill in the timeline a little bit too, so we're expecting in July would be us reporting back on the roadshow that we're going to do at the end of the month and other public input we've received. That feasibility and impact assessment and some type of straw proposal to bring to you on potential prioritization of that to start the discussion. Then in August would bring a draft report back to you, go back out for feedback in August, and hopefully finalize things in September.
Jeremy, does that feasibility and impact assessment include, excuse me, reactions from the CCOs themselves about how big of a stretch some of these initiatives will be for them, or kind of a standard
We
check?
actually have asked the CCOs for that specifically. We've met with them twice over the last 2 months and had about an hour-and-a-half conversation with them on all of the various options that you're going to hear today. And we've also asked them or invited them that if they would like, we're going to be doing this feasibility and impact assessment internally, that certainly if they have feedback, we'd like to consider that as well. So my sense was my gauge of the room was they probably are not all going to do that, but some seemed intrigued. So we'll see what comes in.
I do think as well, just to that point, the last few months have really been a much more open process. These are the 4 areas we're interested in. I mean, there have been some specific questions, but in effect, what are all the things we should consider? What are all the ways we have to think about this? We're definitely moving into a phase now where there's a kind of discrete set of policy options under consideration with varying degrees of both impact and what it takes to accomplish them. And I think the kind of input that will be most helpful at this point will be direct input on those policy options that are under consideration and getting a sense of feasibility from multiple different stakeholders. So I think it's a really good call out. I did also want to just say, sorry, Jeremy, quickly, we didn't do committee updates today as we usually do. We do still have the digest, as you saw in the in our materials, so hopefully folks got a chance to read that. And just also I acknowledge that there's a relationship connection between a lot of the work that we're doing and those committees, because a lot of it's coming up from those committees. Is there a question from staff?
No, there's no question. There's an additional public comment that came in, so we'll talk to you about that.
Okay, I think we can fit it in, so, yeah.
Great.
Jeremy.
Well, I'm gonna turn it over to staff. I think the first one up is Mike Morris and Jackie on behavioral health. I'll just say while they're getting ready to, part of the feasibility impact assessment is also going to be a deeper dive internally on our capacity on some of these issues. I know that's come up quite a bit in the past, and so we're thinking about this as sort of like we do a bill analysis of making sure that these ideas are hitting every part of the agency, and we're getting feedback on really how operationally difficult or feasible are they. Oh, okay. Why don't should we just hang tight for 1 minute? Did you want to move forward, or they had a question about whether you wanted to do public comment?
Oh, we'll do it in an hour. We're okay.
Okay.
We're good.
Yep.
Okay.
Good morning. I'm Mike Morris, Behavioral Health Policy Administrator with Oregon Health Authority. And next to me, I have Jackie Fabrick, who is a Senior Behavioral Health Policy Analyst with our team. And so we're going to be going back and forth in the presentation to give you a little bit of break from me talking all the time. So, and I appreciate the chair's comments regarding where we're at, and we don't have everything worked out, and and we are continuing. Actually, I wish we were at the point where we were saying we got it all worked out, because then our summers would be free. But we are still actively working on all these policy options, and we'll greatly appreciate your feedback today. So. So the first thing, just want to acknowledge that we had folks from across the agency, across divisions, participating and working with us on this, these different proposals and policy options. Then back from the Behavioral Health Collaborative Report, excuse me, we won't spend a lot of time on that. We've talked to you before about the Behavioral Health Collaborative, but I think I just want to emphasize that this has all been in alignment with the feedback that we received from stakeholders, and we're moving forward. The problem statement emphasizes a lack of coordination, integration of behavioral health services in regards to the funding stream, and we will, throughout the presentation, really focus on the experience for consumers. And a consumer may not directly experience the funding issue, but they will experience, for example, going into one provider, by the way, the contract is with, for behavioral health is with a different provider. And so that is how the consumer would experience that, perhaps. There's limited access, there's long wait times to get into services. So I'll turn it over to Jackie.
So, as Mike mentioned, we'd like to keep the consumer part of the focus today as we discuss the CCO 2.0 policy options. So we put together a story of someone that we might encounter in Oregon. A lot of what I'm going to share are examples of things that we have heard that are not working well within the behavioral health system today. So the story we're going to tell today is about Jane. Jane's a 22-year-old female living in rural Oregon. English is not her primary language. She was diagnosed with bipolar disorder in her teens and has been continuing to see her primary care doctor for medication management. She's very comfortable with her primary care doctor, and the clinic is also a a patient-centered primary care home. So Jane would like to continue to have the treatment with her primary care doctor, where they have a behavioral health team. However, because the CCO contracts the behavioral health benefit with another entity, her primary care doctor is not able to receive compensation for the care there. Jane begins to decompensate, and so her team at the PCPCH refer her to the behavioral health entity. However, there's a 3-week wait for her to get into treatment there. So the behavioral health team at the primary care home decide to continue to see Jane pro bono to help manage her situation while she is decompensating until she can get in with the behavioral health entity. However, Jane reports to her primary care doctor that she's feeling suicidal, and it is escalated enough that they refer her to the emergency room, where she is held for up to 10 days while they're waiting for a bed for Jane. So these are situations that we unfortunately hear a little too often in Oregon. Fortunately, what we do know is that there are situations where this is working, and so I'd like to quickly share a couple of those before we get into the policy options, so we can have some examples of where things are really successful in Oregon and where an individual like Jane is able to receive the care that she needs. And so part of this is what we envision for Jane and for everyone in Oregon is that services should be accessible. She should be able to receive services where she wants to receive services, not only in certain situations. She shouldn't have to wait for services. She should be able to receive services as soon as she needs them so that we can manage her symptoms quickly and effectively and efficiently. Services should be integrated, And really, all individuals should have access to behavioral health services at the right place at the right time. So a couple of quick examples of where things are working really well. Options for Southern Oregon is a PCPCH, patient-centered primary care home, and also a CCBHC, a certified community behavioral health clinic. And in Options, they've expanded a standard access model throughout the community. So they're in schools. And how this could work for Jane is that at her primary care doctor, they could have a laptop, they could connect immediately to the behavioral health provider at Options, and begin the behavioral health care at that moment in that office and get Jane transitioned to services. So this idea of really community collaboration, working throughout the community, and being able to use telecommunications, video conferencing, telehealth to have access immediately instead of having to wait for services. Another place where we see this working is Virginia Garcia. And they are also a PCPCH, and they are also in schools. They also have medication-assisted treatment for opioids within their primary care offices. They also have an open access model, and what they discovered was within their primary care home that that physicians were frustrated because they couldn't get access to the behavioral health team, so they modified the schedule so that at all times there was a behavioral health staff available. And they also used a grant to get them cell phones so that the doctors could call the behavioral health team whenever they needed to, so that they could contact them and say, I have someone in my office that needs assistance. And then lastly, Springfield Family Physicians and Center for Family Development realized that there was a need in their community, and they developed an integrated care model. And they're having increased access. People are not having to wait for appointments. They're getting it immediately. Their CCO even developed a pilot for them where they had a value-based payment methodology to be able to pay for services either within the PCPCH or the behavioral health home. And it increased access and satisfaction for the behavioral health team and the primary care providers. And the clinic even said that they are having great success of getting doctors to come to work in their clinic. They're very happy there. So these are some examples of where we see things working, and how we've also looked at our policy options for CCO 2.0, how we can build on successes to try to resolve some of the issues we're seeing in Oregon.
In the development of the policy options, we have done several things in regards to working with groups. We've had, as you see, meetings with a variety of stakeholder groups. There's still actually just one more. The Health Information Technology Oversight Committee is this Thursday, and we'll be reviewing this with them also, getting their input. There was also a survey where we had a tremendous amount of feedback regarding the policy options for behavioral health specifically. And on the next slide, I won't go into a lot of detail, but it just reinforces what we've already talked about. And as far as the things that come to the top are making sure there's access to the full continuum of care, there's more ready access. And one of the things I wanted to emphasize for access is sometimes we talk about access being someone getting in for an appointment. And sometimes it's not just getting in for an appointment, it's getting in an appointment with the right type of provider to address the particular issue that someone's coming in. So that it's a kind of a two-tier. One, can you get in through the front door and get that first appointment, but is it with the right person? Can you get in to see a psychiatrist or a nurse practitioner, a prescriber, if that's necessary? So we decided to do a little bit of reorganization of our policy options. We think this is a much more easily understood way of grouping the policy options. There's probably other ways of grouping it, but we think this is a way that would make sense as we move forward in our planning. So we're looking at the three areas. One is behavioral health integration. Then the provider network, making sure there's an adequate provider network, and then access to the right service at the right place at the right time. So we'll go through each of those. Starting off with behavioral integration, we have several slides and policy options that we're talking about. One has to do with behavioral health integration, and it's far as accountability. So the first step we see is being able to refine our definition for integration to the point that you can operationalize it, and from there you can develop metrics, and then the next step would be is providing technical assistance, or even incentivizing integration based on those metrics. But we felt we really need to get to the refined definition of the integration. So also, we've talked about before is behavioral health home recognition. In 2015, it's been a while, 2015, there was a Senate bill that was passed, Senate Bill 832. What that did is in the section of the statute around CCOs, and in particular patient-centered primary care homes, they inserted behavioral health homes. So any place you saw patient-centered primary care homes, it would be and behavioral health homes. And it directed Oregon Health Authority to develop standards for behavioral health homes. And then there was other requirements in the statute that the CCOs are to the fullest extent possible to encourage and develop and support behavioral health homes. However, due to financial issues and a fiscal related to the bill, they removed the section that says that that Oregon Health Authority would then go out and do these review programs in light of the standards for behavioral health homes. So that was removed. So our authority and our direction to go out and approve these or recognize these behavioral health homes is not there. So we're looking at ways that we can then go to the legislature to ask for that direction and then staff it up so we can go out and recognize behavioral health homes. Then we can implement the rest of the statute as far as working with CCOs and is working with them to incentivize and support behavioral health homes. So that's what that's about.
Can I ask a clarifying question? So is the concept behind this is that patient-centered primary care homes and behavioral health homes are the same entity, or are these two separate entities?
Yes. No, they could be one or the other, but primarily what you're talking about is a behavioral health provider providing patient primary care services within that behavioral health setting. For some individuals, their primary access and their primary contact with the health system is behavioral health. And so we want to be able to have primary care services in those settings so that they can access primary care at the same place.
Okay.
So it would not be, to clarify, Mike, so it would not be replacing the primary care home standard. It could be that a home could, or a clinic could have both, but it's really having a clear set of standards on the behavioral health side like we do on the primary care side.
I guess the main reason why I ask this is that we have difficulty recruiting primary care into certain areas, and this feels like another competition, so to speak, of I imagine this model probably works well in some places, but I just would like to see somehow primary care clinics somehow working with behavioral health to create one entity versus two entities trying to do similar services. Does that make sense? Maybe at different levels, but still.
With our certified community behavioral health clinic demonstration that we have with the federal government, we layered on an additional requirement for the second year, which we are now into the second year of that, is to require primary care on site. And some of those clinics, the way they've accomplished that is with partnering with a primary care clinic. So it's not necessarily in direct competition with that. Those are issues that will need to be sorted out. We have seen that kind of people getting concerned about the competition and, dividing up the primary care services. So along with integration, some, as we talked about, is behavioral health homes or even patient-centered primary care homes are models regarding integration, but there are other things in regards to integration related to care coordination for folks. Some folks will need to go to maybe multiple providers to get their multiple needs met. And so we want to emphasize care coordination, develop standards for care coordination, establish an outcome measurement tool so we can actually track and what is happening regarding integration or care coordination. And specifically, we believe there is a strong need for individuals with adults with serious and persistent mental illness and children with serious and emotional disorders to have access to care coordination. Now, one of the things that we have seen out in the community is that you do have care coordination, but it tends to be episodic or in different places, in different locations. We don't want to layer on another layer of care coordination, but we need to, as we move forward, how we can bring that care coordination so we're not duplicating efforts and that there is more consistent care coordination for individuals with complex needs. I won't go into all the details in this slide, but we can get you the details. There is quite a bit actually happening in this arena. And that is electronic health record, health information technology. We want to look at developing an incentive program for behavioral health providers to improve and develop EHRs and other technology health information exchanges. We see that this is really key. We did a survey. Our Office of Health Information Technology did a survey, and 75% are still seeing the need for, not either developing or really enhancing or bringing their EHR up to a level that is workable and able to share and coordinate care across providers. There are some things that are happening at the federal level. There have been some incentive programs for EHRs development, but they have not been accessible by behavioral health providers. So we're keeping an eye on what's happening there. There is some movement to, as it goes forward, to include behavioral health providers, so that will help us as we work to move this policy option. We want to look at CCOs requiring supporting EHR adoption, and that also that behavioral health providers have access to HIT and hospital event notifications, require CCO utilization of hospital event notifications. So what we're talking about there is at provider level that there's use of hospital event notifications, but then also the CCO be tapped into that so that they are recognizing when their members are accessing acute care or emergency departments. So one of the things that we have recognized, and this is, as we said, it's not all for the CCOs. We need the CCOs to do things, but there's also things that Oregon Health Authority needs to step up and tackle and do some changes. One is there are billing barriers still for integration, either providing physical health care in a behavioral health setting or vice versa. There are still issues with making sure, a nurse is credentialed to do physical health care and has the right provider number for that, as well as behavioral health, and there's some challenges there. So there are a variety of issues around this, and as we've seen some of the examples, some have figured out how to do it, but they shouldn't have to figure out how to work around our system. So we want to look at changes that need to happen, develop additional payment methodologies to reimburse integrated services, and then achieve equity in behavioral health and physical health reimbursement. This is a much more complicated issue to tackle. There's a lot of moving pieces and drivers to this issue, and so, but it is, as you've heard in public testimony, there is an issue for our workforce and a high turnover in our workforce, and a lot of it has to do with inability to make a living wage for the lowest level, and then just attracting high-quality talent to Oregon for behavioral health. So looking at that issue and ways that we can address some of the drivers for that. Evidence-based practices and emerging practices is another area that we want that would improve access or integration for behavioral health and physical health. It would be helpful to update OHA's listings of evidence-based practices and to take some leadership in providing that direction or that compiling information. We don't see ourselves as being the experts, but we need to bring that expertise together to develop a list of emerging practices as well as evidence-based practices. In looking at outcome measures for using research-based practices, work with CCOs to provide clinical trainings to fund their provider network to get them trained in evidence-based practices, and then incentivize the use of those practices going forward.
So I'd like to take this back to Jane for a minute. And in the current state, Jane is unable to receive behavioral health care in the setting that she wants to receive it in, and she's having a difficult time getting the access to the level of care that she needs when she needs it. So by implementing these policy options, we envision that Jane would be able to receive the behavioral health care in the most integrated setting. That would be by integrating behavioral health, holding CCOs accountable, and OHA working through some of these billing issues. I also wanted to mention, because I realized we hadn't mentioned it today, when we're talking about behavioral health today, we're talking about substance use disorder and mental health. So I just wanted to call that out, that we could be talking about any diagnoses within those two areas.
Okay.
Got an integration question for you.
Yeah.
So I've heard two things about behavioral health integration over the last 5 years in the CCO model. One, anecdotal. One is we didn't put a lot of requirements into the notion of behavioral health integration because we just assumed that there'd be good intent at the local level, and we wanted to let local communities do what they would do. And the other one is it just sequentially wouldn't have made sense to start with behavioral health integration. There was too much else that was being stood up in the system. So it's actually the right time to really be focused on behavioral health integration. In either case, they're both kind of responses to the fact that behavioral health integration hasn't moved at the same speed as some other elements of the process. So my assumption is that the policy options that we've got in front of us are really designed in some fashion to affect three different things. One is changes we want to see in OHA's ability to manage the integration process. A second one is clearer expectations for local communities, CCOs, and regions about the kind of integration and change we want to see. That looks like mandates in a lot of places, I think. And then the third one is increasing resources available to local communities to be able to make the kind of change that we all want, including those local communities. What amount of effort in these policy options is represented in each of those areas? So if you're really kind of saying, how much is this about changes we need to make at OHA? How much is this about clearer expectations and mandate? And how much is this about opening up space and creating resources at the local level? And I know it's different with different options, but just thinking about this integration space, kind of where's your energy and effort as an organization right now?
So, and I think what you're pointing out is the three areas are a great way of looking at that. And I can say that what we've done is we've had fits and starts, or we're having some focus areas in different areas. Like, for example, the certified community behavioral health clinics. We took the behavioral health home standards that were developed by another group and we applied it there, but we're not applying it elsewhere. So this is to take some of those efforts that are going on and broadening them. But we can go back as far as even kind of characterize them, which of those three areas are the focus that we need to, to what degree do we need to increase in each of those areas to meet the overall goal of integration.
And I'll just throw something out if I can that staff have raised to me, but feel nervous to say, so I'll say it. That, they've said, Jeremy, as we're looking at some of these issues, some of these are already in contract. Should we be telling the board that? My answer has been yes. Part of this process needs to be thinking about what did we already require, but for whatever reason, it just didn't happen. So I think that's also something we need to, in the next phase, look at is, are these really new or are they variations? Or just trying to put, a stronger focus on things that we were already expecting in the first round. So.
And I think John has raised that point a few times in terms of looking at the accountability of across CCOs and who's meeting metrics and who's not. This is something that we haven't really gotten a handle of.
Well, and I think as you look at that is why aren't they? What are the foundational issues? And I think you have touched on some of the foundational issues. I think payment issues and contracting issues, those are functioning as barriers for CCOs in order to be able to do some of these services. I don't necessarily think it's a lack of desire because it benefits them to be able to provide these. And so, and unless we truly drill down and say, what are the foundational issues why they're not already accomplishing these things, and we don't change that, then I think setting the same expectations is not reasonable, essentially, so.
I think it'd also be really helpful to get an understanding around the cost savings of some of these integration models. And so we had 3 different models that were highlighted for us. If I think about the differences between them, one in a behavioral health setting in the context as you described in options, and the other 2 in primary care context. So ultimately, if we put a cost layer onto that, do we see, we certainly could see better access in those models. Could we also see better cost containment for the overall system? That'd be helpful.
Would be a way to prioritize which to do first.
Yeah. And I would just kind of echo, I think, Carla's comment on the integration model. I'd like to see that the both options are actually available in the policy statement, because as I've considered the primary care view of integration of behavioral health, I don't know that it necessarily meets the kind of standards that you're describing that the community behavioral health component and embedded primary care does. And so some sort of equilibrium among those models might be really helpful to see. Yeah.
I guess I would just say, to show my cards a little bit about those 3 areas, as I think, there's a lot here too. So if we assume just for a moment that all of these options make sense and we just need to go do them, then it becomes a sequencing question. And for me, as I think about sequencing, I'm really interested in where, there seem to be blockages in the stream at each level. So I'm really interested in how kind of far up, you got to kind of get rid of the blockages at the top of the stream before you can actually see the flow moving. So if the top of the stream in this case is OHA, thinking about where and how we're removing those blockages in a way that start to move resource, and I don't just mean money, but start to move resource effectively to the local level, and then it's easier for us, I think, to begin to have different expectations and to be clear about those expectations and to support those. So as you're thinking about, as we move into September, kind of the sequencing of these, that's part of what I'll be looking for. So,
I also just one other, since that sort of sparked the question that we heard about in public testimony around the carve-outs for the state hospital as well. So some modeling that would help us understand what exactly that would look like. I don't see it in this material yet, but I'd be interested in learning more about that.
Yeah, that's a great point in regards to the sequencing. For example, if we were pushing, started at the behavioral health home, and we're going to push that, and we're going to get everybody, but we haven't addressed the billing issues. Right. And then, the billing and then address
yeah,
that.
that'll be really helpful to see. Thank you.
Can I make one last comment? So just looking through the behavioral health guiding questions, I guess one of the things I'd like to see in here is discussions about work with families. You can't work with just one individual and assume everything is going to come out okay. And then I would like to see more questions related to preventive issues, so that the hope would be that you would minimize having to utilize this, particularly around the areas of children, the services around children. It feels like to me if we did work up front, then we wouldn't have to focus as much on services that we're offering to kids, and that work always has to be within the context of families.
Great, thank you for that. Okay, let's talk about
Access.
some of those issues in regards to access. And so just one of the things that we're doing is aligning the Oregon Performance Plan. That's our work with the U.S. Department of Justice, our Behavioral Health Collaborative, what's happened there, and our Medicaid waiver, get those things all aligned. One of the things is in regards to the Oregon Performance Plan, we are already working on the language in the 2019 contract to align the contract language with the OPP. So that is moving forward, and then we'll see what needs to happen beyond that with CCO 2.0 for 2020. There was the issue of clear ownership of the behavioral health benefit by the CCO. So this one's, some people have characterized it as carve-outs, get rid of the carve-outs and things like that. But it's really, I think we really need to get to the crux of the matter in that, there's a global budget and making sure that the CCO operates, those three benefits from a standpoint of a global budget. And oftentimes with the contracting, sometimes it is a capitation and a carve-out. Sometimes it's just a contract situation. But where the CCO kind of delegates not just the management of the benefit, but oftentimes the responsibility for that benefit. So you go to the CCO and ask, talk to them about an issue with behavioral health, and they may point you to their contractor, talk with them about that. And so this is really to bring that together and make sure that the CCO is, the way we're characterizing it, taking ownership of that behavioral health benefit. So risk sharing for the state hospital, that's what's mentioned. There was actually, from the Behavioral Health Collaborative, there was a governance and finance group, and then there was a subcommittee looking at the risk sharing for the state hospital. So we are actively working. We had a meeting just last week looking at what that would look like. We're beginning to look at financial models and regarding rolling that over to CCOs. We're looking specifically for, there's multiple populations at the state hospital. We're looking at the civil commitment population and not the forensic, because that's a different animal as far as how you tackle that problem. So, so we're working on that. It's kind of in parallel with the CCO 2.0, so we're making sure that those two work streams are working together so that we're achieving the intended outcome. So that is, we're shooting for, rolling that over at the beginning in 2020. That's ambitious, but we think we have a good group of people working together to move us in that direction. So the other aspect of our adult mental health benefit is the residential, adult mental health residential is still carved out, and OHA pays for those services on a fee-for-service basis. It's a very complicated benefit and financial model, so we are working in stages to standardize the rate that we're paying and then get things set up so that we can transition that benefit over to the CCOs. It doesn't make sense at a high cost service that be carved out from the rest of the continuum of care.
Just, could you tell me what the Oregon Performance Plan is? I'm sorry.
Yes, we, it goes much further, but about in 2010, the U.S. Department of Justice came in to examine our community mental health system for adults, and under what's the Americans with Disabilities Act, and specifically a Supreme Court decision called Olmstead. And it's looking at, are people being with mental illness, adults, are they being inappropriately segregated from the rest of society? And so institutional care is kind of the bane of that. And so looking at building up the community system so people are not in institutional care. So this gets to one of the other issues that we have been discussing about, and that is children, ensuring there's access to behavioral health, continuum to care across the lifespan. We need to prioritize access to early intervention for 0 to 5. And this gets into, we need to get upstream ahead of these issues as we move forward, and there's other aspects of that we'll address and other options. Adopt mechanisms to assess the adequacy of services across the continuum of care. It's really difficult, challenging right now to say whether or not there's adequate access to the network of care. So we need to develop mechanisms to really assess that, and what does that look like. Require CCOs to ensure gaps in the continuum of care are addressed and consumers have access to a diverse provider network. This is an area in regards to individuals having access to services and not be limited to just one provider that happens to be in their community. Becomes definitely much more challenging in our frontier communities, but you also see that in more urban settings. So we want to make sure that there's access for that early age and across the continuum of care and for that entire age span. So the other is to ensure that children's behavioral health system achieves measurable symptom reduction and that there's more targeted services. Require outcome measure tools for providers. This is where a provider is using a specific tool to measure the outcome for individuals that are being seen there. And then the other, as we talked about, is invest in prevention services for children. This is like one very small, simple line, but I think we need to expand on that.
And their families.
And their families. So, yes, and we should make it more explicit as when we're talking about children, we're talking about their families, children in the context of their family. So, look at working with CCOs to develop a train-the-trainer to invest in new behavioral healthcare models, and then CCOs with the support of OHA invest in supporting providers to implement trauma-informed services. This is a large area that cuts across not only behavioral health, but physical health care, oral health care even. Speaking as one who has been traumatized at a dentist's office. So it is really important that we emphasize that. There's a lot of work that needs to happen in regards to assuring that trauma-informed care is occurring for individuals receiving services and members. And then also to ensure special populations, individuals with complex needs, have their physical and behavioral health needs met by the CCOs and system of care, prioritizing children and child welfare systems. Enforce contract requirements, as Jeremy was alluding to or speaking to earlier, around the coordination of care for child welfare and making sure that's happening consistently and that we're achieving the outcomes for kids in partnership with child welfare. Then also that we, for individuals and kids with IDD, and working with that system, who oftentimes experiences a lot of stigma as well as barriers to access for that challenging population. So. Next is to provide ample incentives and opportunities to work across systems. There's a system of care which is being implemented. We want to see full implementation across the state. Require wraparound is available to all children and young adults who meet the criteria and fund those services. That's a challenge as far as how you assess kids and making sure kids are being assessed as needing a wraparound and then assuring that they get those wraparound services. And then incentivize CCOs to develop approaches to meet the complex needs of children and young adults and their families.
So taking this access issue back to Jane, so in our example in the beginning, Jane was not able to receive the right level of care at the right time. And these policy options would ensure that Oregonians have access to the full continuum of care when they need it and where they need it. Additionally, we've made progress in Oregon in implementing trauma-informed care. And we can continue to make progress, and we'd like to see that in CCO 2.0. So instead of Jane being asked, what's wrong with you, she would receive her treatment within a trauma-informed organization and with trauma-informed care. And lastly, the systems would be working together. So if Jane was involved in another system, say she was involved in DHS or child welfare or corrections, the systems would be working together for the best outcome for Jane.
Okay, the last.
Any questions or thoughts on the access? The one thing I was just going to say, I mean, this is across the board, but in this area in particular, there's a lot there. And at this level, but partly because of where we are in the process, it's a lot of it is framed as a kind of set of hopes or desired goals that we would reach. As we move into September, I'm sure you can see it in a few places, but some more detail there about what this actually looks like. That'll just be really an important piece for me to understand, both in terms of what it requires at OHA and then what it requires or creates as space at the CCO level.
Absolutely, you wanted to see exactly what it is that we need to change or add.
Yeah, I mean, part of it is it feels like there's enough complexity in the behavioral health system and the degree to which it does or doesn't integrate with our physical health system. There are enough ways in which the system is and feels broken to people that it's really easy to go to a place where we just start to kind of create these aspirational statements. We ought to do this, 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 which I think we could probably, which a lot of different people could do. And again, I think we're at the right spot right now, but getting underneath that and saying, what do we actually think the right sequence of activities are to begin to improve access for some particular populations? And what are the resources required to do that? Are those resources we have in our system, and it's about shifting those resources? Are those resources that need to be shifted at an OHA level? Are they resources that need to be shifted at a CCO level where we need to be clear about expectations and then support that? Are they resources that need to come in from other systems? Or is this, I mean, there's always just kind of the basic supply and demand question, which is a real critical one in this area as well. Where is this about literally new resources that we need in particular places in order to try to build this out? So getting some more clarity about that as we move into the next couple of months. And it's also a place where, to Brenda's question before, where I'm really interested in CCO's perspectives on some of these issues as well in terms of what it takes to get there.
I think, Zeke, also, if I hear your question or your comment around driving deeper into the accountability, so it'd be interesting for me to know what the concrete expectations are specifically around access, and then what is OHA's responsibility if those access needs aren't being met? So what do we have the contractual authority with, as you mentioned earlier, Jeremy, on things that are already in there that we haven't exercised the muscle, so that there's more and more accountability in this space around performance.
So what I'm hearing is we need to not just operationalize it, but also think about it in the whole. And so that as far as the sequencing and so forth, and not just implement these variety of things, shotgun approach, but as a whole, what is the steps we need to take to accomplish this?
And to Brenda's point, I think that sequencing is informed by cost-benefit analysis, where you're going to get the most bang for the buck. And going back to John's point in terms of looking at heterogeneity across CCOs, to both inform not sequencing, but also monitor progress in real time. And maybe it won't be this group, but there will be a group designing a CCO 3.0 in 5 or 6 years. I think having that information is going to be really important for CCO 3.0.
John did tell me that he wants to be involved in 1.0 through 5.0, so he may still be.
I make it.
Another way to that I was just thinking about with that is with those 3 examples you gave before, I can't tell just from what I've seen, where is that about innovation that is occurring at a local CCO level where they're going and pulling different resources from different places in order to build something? How sustainable is that? Because the way you do that is you go and you get grants from places. And
Yep.
if you're lucky and smart, those grants are invested in a way that they're not, that they either reduce other costs or they don't require that they're going to be sustained over time. So I don't know from those three examples where it's about just saying, hey, every CCO, you should do what they did because they were smart enough to do it, versus where it's about kind of a set of elements and leveraged opportunities that were in place. And so if those are unique, interesting, unique, and not reproducible, that's valuable, but it's not really helpful as we think about the system. If there's something to be learned in each of those environments about what they were able to do that we all ought to be able to do in different spaces, we want to pull those out. So as I think about these different policy options, I'm just trying to think of really where we're freeing up the space and then being really clear about those expectations about what we want to see about per se.
Yeah. Yeah,
Thank you.
Yeah, thank you. I think that's a great point, and that each of those have things we can learn from and look at how we can replicate and remove barriers.
Okay. The last section is on provider network. So one is to implement the behavioral health collaborative workforce committee's recommendations. One is an assessment of behavioral health workforce, or actually scheduled to have that completed January of 2019. Update our mapping tool. We'll then use that data to update our mapping tool with the idea then we can use that as a tool for looking at investments and developing strategies to address workforce shortages. And then part of that is to develop a recruitment and retention plan. And then we are working on finalizing competencies of an integrated behavioral health workforce, so that will be accomplished this year. And then one that is actually quite a ways towards accomplishing this is standardized suicide risk assessment, so that we can have a research-based tool that is being used across the state, and then we can use that for collecting data and targeting resources to address the suicide issue. So. Next is to increase access to culturally and linguistically specific best practices. This only touches on this issue. We are in close collaboration with the social determinants of health and health equity group, and as far as looking at specifically behavioral health issues around health equity, and this is one we need to ensure or require that CCOs develop culturally specific services for individuals and have that available, or at least practices for those specific populations. Develop a diverse behavioral health workforce who can provide culturally and linguistically appropriate care. It's really important. It's much more difficult in using translators, interpreters, in doing therapy and doing some of the behavioral health interventions. So that's why it's important to develop that workforce that's bilingual or bicultural. And then implement the recommendations of the Traditional Healthcare Workers Commission, and this is part of some of what you would see in the social determinants of health and health equity recommendations.
So to bring this back again, first of all, we know that we have a behavioral health workforce shortage in Oregon, so we've been taking a lot of steps internally at OHA to be looking at how we're addressing that, and Mike mentioned the workforce assessment, and we're building a retention and recruitment plan, and we'll have that all available on the behavioral health mapping tool, so it's available to CCOs as well, to be able to look at the workforce within their region and for providers to make sure that we have that network adequacy. So that will be a couple of years out, but once we have that available, and then with other efforts we have underway, ensuring that we have providers in the local community that are qualified and prepared to do the work. And that includes a culturally and linguistically appropriate workforce so that Jane can receive services in the language of her origin as well. So this will also increase access, make sure that there's core competencies for individuals, and that linguistically and appropriate provider network.
Okay, in summary, what we're looking for and aiming for is integration of behavioral health into physical health care and vice versa. Address billing barriers related to that. CCOs ensure there's a full continuum of care, recruitment and retaining a workforce to work in integrated settings, ensure culturally and linguistically appropriate services, and more importantly for OHA is to hold CCOs accountable for behavioral health benefit and moving forward. So final is the questions of reactions. I think you've been doing that after each section, so we're interested in anything else you have to say.
So the only other thing that I would love to see added into the section, particularly around access and provider network, is telehealth. I think that the behavioral health is a good area in which to utilize telehealth. There's actually been good studies to show the effectiveness, particularly with young people. They connect with the screen more than a person sitting across from them. And I think that has to be built in a very tangible way in order to get CCOs to assist with that. I think it's been left to each of the clinics to develop this, and even though it's a lot easier than it used to be, it is still a daunting process to do this. And to be able to provide resources but also guidance at the CCO level to help facilitate this, particularly within these concepts of the behavioral health home and primary center, patient-centered primary care home. Telehealth in this arena would be such a great fit in rural areas and would allow you to have these culturally and linguistically appropriate workforce members for those populations in which otherwise it wouldn't necessarily support that. So, but I think that has to be built in here. I don't think we can say, and may we suggest, I think we actually have to say part of that program should be looking at telehealth.
Great comment. Thank you. I think what we do is we rely on, providers to try to solve a problem and turn to telehealth, but as far as pushing it from the front end and, requiring advancements in that area and support of that.
I think three things. First of all, I think the way you've presented this, for me, is much more manageable. I mean, this is an area that I struggle with. I feel like I now get it more, and, can manage it to some degree. Second, it does make me uncomfortable that we're evaluating organizations kind of feeling in the dark. It's great to hear that there are people who are getting it and appear to be doing it right. I hope the folks who sit here 5 years or 6 years from now and are looking at CCO 3.0 will see an evaluation of each CCO based on reasonable criteria. We're not talking about the kind of more sophisticated performance metrics that are public and we all see. But there should be an evaluation package. I mean, surely the CCOs must have goals and somehow there must be a way to get to an evaluation package that will enable a future Oregon Health Policy Board to see who's really getting this and who has moved on all of these areas versus who's really struggling. And why are they struggling? And what can we, or what should we do? The third is one thing I don't see here. I think it's a significant area, is drugs. Where are the prescription drug issues fitting in here? I think that's a substantial portion of the budget. I know mental health folks who are on medication is a significant percentage of the folks who are getting prescription medicines. Those used to be a huge issue. Maybe they're less now because they're more generic. But since some of us are involved in that end of things, I think you have to ask, so what's happening around prescription drugs in here? And who's at risk for that? And who's accountable for that? And what's going on there? And as you know, this can be significant because many mental health folks take care of mental health but can't prescribe the drugs. So,
Yeah, and I would include medication-assisted treatment as part of that.
I have a question. You know, as we think about the first evolution of the CCOs and now into the second phase, I think some of the debate around this board is how much tension do you put into these big systems? What's the right amount of tension? You know, if it's too little, then systems really don't move and improve to serve Oregonians, and if it's too much, then the systems react and flip out. Not that we've seen any of that. Anyway, so I'm curious for you, how much at the sort of a high level do you think these policy statements represent a stretch at the maximum level without flipping out?
To be honest with you, in regards to, I think it's a stretch. I think it's what we're seeing is a lot of things we know need to be done, and we, for whatever reason, we haven't been doing. The system hasn't been organized to support moving in the right direction. So I think it's a stretch, but I really don't think it as, you know, just this huge challenge that, you know, we'll give it our best try and we'll see what happens at the end of 5 years. But I really do believe that we're at a stage where we can actually move it forward. It's a stretch, but I think it's attainable.
Are there big controversial elements in these policy options that we should be mindful of?
So I think one that I haven't heard anything, but this is me anticipating that there may be some discussion regarding what it means for the CCO to take ownership of the behavioral health benefit, and kind of way people may be reading that. They may have some ideas that we're going to outlaw, you know, subcapitation, for example, or so forth. So I haven't heard anything yet. That would be potentially one area.
Did you, David? Yeah.
No.
Just in terms of both interests in the kind of the broad set of policies that you raised. One specific thing that kind of touches on what I was talking about before, the bullet you have about requiring CCOs to develop best practices to reach culturally specific populations. So like in my mind, that's one of those places where I think the requirement should be on developing best practices is at an OHA, or on surfacing best practices is on an OHA level. The requirement in my mind there is implementing best practices around culturally specific populations and services and supports. I don't think we want 15 different solutions to what that looks like based on kind of where you are in the state. So that's one of those places where I think about with each of these policy options, who are we asking to change behavior, right? And on that one, it feels to me like the first thing we're saying is we need a statewide both recognition and clarity about a commitment to culturally specific services and the value and the importance that's there. And then we need to create tools that really support local communities and push them to incorporate those kinds of services appropriately. So there's a relationship around change at each of those levels. But for me, it starts at OHA, and then that's about how does that create clearer expectation and then accountability. And in some communities, that'll look like, great, this is what we've been really wanting to be able to do. And in other communities, there's going to need to be a push and pull, I think, between OHA and those communities to move there. So it's just an example of how I think about that. I'm really interested in terms of prioritizing different things here. I don't know whether these are right or wrong. I'm mostly interested in hearing from other people about what the right sequencing should be. But if you're asking me, which you are, I think that I'm really interested in this alignment question. There are so many different places we've said this is what it ought to look like. And I can't tell if we're just kind of slightly out of alignment. I don't think so, but I can't really tell if we're just slightly out of alignment or if we've got some real work to do to make sure that the Oregon Performance Plan and the recommendations out of the Behavioral Health Collaborative are really supporting each other effectively. And then I'm really interested as well in kind of how do we get clear about who has control over what resources, and then what our expectations are about how those resources are connected to a set of outcomes we want to get. Whether we want to call that carve-outs, whether we want to call that a full global budget or not, I just want to understand kind of where the locus of control around activating those resources, around the outcomes we're looking for are, and how these policy shifts and changes create more clarity there and give us the ability to move forward.
I guess to add maybe to that is that one of the questions that I have is, in order to achieve this, how much of this is goals that can be achieved within the Oregon Authority, and how much of this requires legislative changes? Because my suspicion is that some of this will require legislative changes, and that, I think, adds a layer of complexity onto establishing these goals, and also might impact the priorities of this. So I think it would be nice to, when we come back for another look at this, to understand where that change would have to occur.
Yeah, great point. Actually, we're already started, Jackie's working on looking at each of the policy options. Is it a contract change, or is it a statutory change that we need to make, or even a rule? So we're beginning that work. Thanks.
I just want to thank Mike and Jackie for a clear, thoughtful, and well-paced presentation. Very well done.
Thank you.
Thank you.
You stole my thunder. Yes, thank you very much. And I also know that there's a lot of work from other folks underneath this, and I also just want to acknowledge that, this was overwhelmingly stakeholders who've given us input to date have been really invested in and thinking about behavioral health and concerned about it. So just appreciate the ways in which this incorporates that feedback. So thanks for your work.
Great. Thank you.
We're going to take a 5-minute break, come back at 10:20. And we'll have one more public testimony, 2 more, and then move into the next bucket. Order, please. If you're sitting in the back of the room or standing in the back of the room, finish your conversation. Or go out into the hall, please. It's hot. All right, great. So as I said, we've got a couple of folks we want to provide opportunity for public testimony, and then we'll jump back into the CCO 2.0 work. So I'm going to invite Ann Casper and Kaha Mohammed up to the front. As you're getting ready, I'll let you know we have a 3-minute time limit per person, and I'll let you know when you've got a minute left, and that means try to finish it up. But thank you for coming in today.
So Kaha cannot hear very well. You have to say that louder for her.
I will say it as loud as I can.
There you go. So no, the 1 minute. Can you explain to her the 1 minute?
Yes, Kaha. So you have
Yeah.
3 minutes to speak, and then when you have 1 minute left, I'll let you know. I'll do this. I'll say 1 minute. I won't say it. I'll actually just kind of do that. And that means you have 1 minute left, and then so just finish up. So thank you for coming today.
Thank you.
Yep.
Go ahead. Okay, I just don't see Jeremy and, oh, there he is. Great, he is there. Hi, I'm Ann Casper, and I just will go very quickly over, I believe, 3 topics. The first of all is for the CC 2.0. I'm very concerned about having one person for behavioral health in charge of it and not having deputies or 2 people, for example, one for mental health, one for addictions. It's almost like you have a manager who's trying to manage golfers and football players at the same time. It's just very different categories, different ways of even approaching health. So I would suggest having either deputy people, because one is going to lose out. Either addiction's going to lose out or mental health is going to lose out. Okay. Second thing is, and I don't really know you all very well. I've seen you speak at big forums before, But I'm also concerned about, you have very heavy responsibilities of choosing these systems that affect people. And how do you get the word of what's really going on in the systems? I think there's a disconnect somehow. And I just want to, for example, the Unity Center for Behavioral Health Care, I think you probably don't even know some of the stories I hear talking to people. And I've gone to Mayor Wheeler, I've gone to Chair Kafori, and I asked them if we could have a listening session with some of these complaints, and that was September, and it still hasn't been there. So I don't know how to get the word to you guys or those people to connect with you. So if somehow in the CC 2.0 there's a way to connect the real people's voices, what's going on. Some concerns are in the PES, the Psychiatric Emergency Services room, really having 20, 30 people in psychiatric crisis doesn't help people heal. For some it does. I would suggest having no more than 8 people in one room, and that's just for healing. Also, for some females, they're getting touched sexually and no one's believing them. So I've heard this from many different aspects who don't have anything to do with each other, so I know this is happening and no one is listening to them. And there's also people walking out of Unity without their medications on the weekends. They don't have live doctors. It's by telepsychiatry. They don't call in all the medications to people. So that's a problem. So I would say, if you want to look success, Crisis Assessment Treatment Center. Now, as far as I'm here with Kaha because I've helped her out now. I saw her crying at Unity. She had been there for 3 days. Her daughter calls her, please see me, please see me. The staff didn't let her see her. And I happened to run across her after 17 years. She was part of my thesis, actually, this thesis, 17 years ago. Found out that the systems are making it really hard for her to even connect with her daughter. Oregon State Hospital, I asked them when her daughter got committed down there to please make the family handbook available in Somali because she, it's easier for her to understand Somali. That's 5 months ago. Nothing. I have 79 pages of emails back and forth with systems trying to help her to see her daughter. Daughter keeps calling, I need help, I want to see my mother. And it took an act of almost Congress, it wasn't Congress though, okay, just to be clear, to get her to see her daughter after 5 months. And why are you separating families? That doesn't make sense. I've been a refugee since 1984. I helped bring in 800 in the 90s. We could find food, housing, shelter for them in Portland at that time. Been with these people for 20 years. I was with a family last night. Their daughter is dead. And she died as a teenager. And part of the problem is that coming from these closed, tight-knit communities, there's not good refugee help. You have no help for the men, veterans, who we fought for us in our country overseas. Because they weren't born here, they can't get veteran services. I would look into that. That's it.
Thank you, Ann.
Okay. Thank you so much. Okay, you ready? You get 3 minutes.
Do you need a mic up
It'd be
here?
great if you could. Thank you.
All right. Hi, all of you.
Hello.
I'm fine. Thank you so much to come. I'm coming to here, and it's my friend, and then she brought me to here. Thank you so much. And my daughter, Muhammad Yasmin, she is in the hospital for Salem. So thank you so much. And so before he was in Portland, she was living with me, and like this month is 6 months ago there, and so she's there still. But I'm so thank you so much for those people, the workers, and all the social worker, everything, or doctors. I'm thank you so much to them because they give into trading so much. She's okay right now. They control her mind, everything. They say, do this, brush your teeth, comb your hair, everything. You have to shower in, blah, blah, blah. They say everything. So I'm so glad about that. I'm so happy so much. Because before she going to the beach and then she said, I have to fall there. I'm going to die. That she said me before. So always I'm so worried so much. I'm so much. I'm so worried because I'm the her mother, the one who's looking after her. It's me only, just no anybody to help it to her, only me. So I'm so hard, worrying too much already. I was so worried so much already, but right now I'm so happy that she's there. So she.
But Kaha, when you call the hospital, do they answer the phone? Do they speak Somali to you?
So,
yeah, that's
little bit.
You-
I have
1 minute.
something that's troubling me, something. The people for the holder for telephone, they know how, or they know big up the telephone. When I send it, they hang up. So that's a little bit. That I have troubling about that. All from there when I'm going to call my daughter. So.
This happens in many hospitals where she calls her daughter, they just hang them up. They don't even allow her to speak to her because she doesn't speak English well, they just hang up. Or she asks for her daughter's name, they hang up. ROIs have been a disaster, really hard to work with. I've had to navigate that. I also have 20 emails on that if you need that.
What was that,
ROIs means you have to get something signed so the person can talk to you. In psychiatry, you can't talk to somebody directly unless the release of information. So getting that help for a person who speaks Somali, and we've done this now with 4 hospitals, and it's always been a struggle to be able, so the mother can at least see her child, and it shouldn't be that hard.
So thank you so much, my friend. She told me about the conference to here downtown, and she said, you go with me, we have to go there about the Yasmin. So right now, thank you so much to meet you. So I'm happy about to come in with my friend and to see you. Thank you so much.
She had
Thank-
a few more things she wanted to say, but we're going to go.
Thank you
But
so much
how
as
can
well.
we connect with you? What's
Yes.
the best way?
Through our email address, which I forget it exactly, but it's they can tell you at the staff table. Yes. Kaha, thank you very much for coming and speaking with us today. Ann, thanks for bringing her. Thank you. Okay, our next area for exploration is social determinants of health and health equity policy. So I'm going to invite up Chris DeMars and Leanne Johnson and Amanda Peden, who have been doing the yeoman's work on moving this through for us. Jeremy, any contact setting while you put fruit in your mouth?
Pineapple's delicious.
Good.
Good morning.
Hello, all.
Hello. For the record, my
Welcome
name is Leanne Johnson. I'm the Director of the Equity and Inclusion Division for the Oregon Health Authority, and I will let my colleagues introduce themselves.
Hi, I'm Chris DeMars, Director of the Transformation Center at OHA.
I'm Amanda Peden. I'm a policy analyst in the Office of Health Policy at OHA.
All right. Well, thank you for this opportunity. We're here today to talk about CCO 2.0 in relationship to the social determinants of health and health equity strand of work. And what we are going to review today is the policy development process, how we arrived at where we are, the implications of that work, and as well as some intermediate results in terms of the community input pieces. So just to give you an idea of who has been working on this, this has been a heavy lift across the agency, especially across several divisions. And the policy team that has been working on this has been led by Krista Mars and myself, along with Amanda Peden, who is the project manager and policy lead. This work has also included other divisions, as you can see from the list in front of you, that include our Office of Equity and Inclusion, Health Policy and Analytics, Public Health, and the Health Systems Division. So it has indeed been a team effort. Today what we'd like to do, specifically 3 things, is illustrate the relationship between health equity and the social determinants of health and how that flows into the CC 2.0 work and policies. We'd like to share some feedback specifically from some of the input sessions that have informed further development of that work. And then also, as you saw with the behavioral health presentation, we also will be running you through a case study that is, quote, a hypothetical situation. However, it's based on real life experience of an individual that is known to one of our team members. So that's what we look at doing in the next 40 minutes or so. On that note, I'd like to head into our first objective, and that is to really look at how the social determinants of health and how health equity, how those are really inextricably tied. So we want to start with that grounding. So also to note that one of our next goals over the next 5 years is truly to integrate more strategies within the health system, within the healthcare system and health delivery system to better achieve health equity. And I use that word very deliberately, that phrase very deliberately, better achieve. Because in 5 years, we're not going to achieve health equity. We will better achieve it. We're not going to improve it. We will have improvements. Because one of the things that we need to note in this work, and this is where it connects very specifically to the social determinants of health, is that we can't undo in 10 years, in 5 years, in 20 years, what has persisted over centuries in this country. We have, when we talk about the social determinants of health, we have social factors that have been a barrier and that have been built to exclude certain populations within this country. And it's no mistake or no coincidence that the populations that are suffering the greatest health disparities and health inequities are the populations that have been most marginalized and disenfranchised over decades and centuries. So we're talking about tribal nations and tribal people. We're talking about people of color. We're talking about people who relocate to this country from other countries, whether chosen or forced to do so. So the whole idea of the connection of health equity is that those that are experiencing the greatest health equities are those that have the greatest barriers, not only to systems, but then also once within those systems, such as the health delivery system, they can be subjected to overt bias, implicit bias, or, as we've spoken about earlier, care that may not be culturally responsive and culturally appropriate. So those are all barriers that exist, which is why we see that health equity and the social determinants of health are very much, as I said, inextricably tied. So this next slide is quite a incredible piece of work that's been developed by the Medicaid Advisory Committee, and it's a graphic that they're using once again to create and illustrate the tie between policy, between CCO 2.0, between health equity and the social determinants of health. So the Medicaid Advisory Committee has built this model based upon best practice and research. And I think that what this slide does very importantly is it really does draw the connection between policy and social conditions and social circumstances, and how policy, good sound policy, can truly address the inequities that exist in multiple systems, including the health delivery system. So one of the questions I think that's also important to talk about, to regard, relates to that which factors in to good health or worse health or not so good health. And so what you have here before you is a pie chart, as you can see, and these are the factors that determine our health outcomes outside of the clinical environment. So you can see that much of our health outside of the clinical environment is influenced by the social determinants of health, including social and economic conditions, physical environment are also part of that. But what's most important is that you can see how healthy behaviors and clinical care have a lesser impact on that. Okay. All right. And once again, we're just providing some more and more reinforcement for the premise that health equity and the social determinants of health are inextricably tied and connected. And what's important about this next slide relates to really, I would focus you on the two bottom foundational pieces of this pyramid. And that's really what is most important. And it also speaks to that the interventions are not solely clinical, but truly an interaction between addressing the social determinants of health, and that includes very closely and tied to public health interventions and how all those factors are foundational factors that lead to better health, and that what happens in the clinician's office is absolutely critical as well. But walking into the clinician's office where you're already in a detriment when it comes to social conditions and circumstances, that cannot be cured 100% within the clinical environment. So these pieces are not to say that one is more important than the other. What it is to say is that these build on each other as a foundation. And what I would want to say now as a segue into the rest of our presentation is that the strategies that we have been vetting, the strategies that we have been proposing, the strategies that we have heard from the community that we've integrated really do speak to health as it relates to public health and public health policy and the overall health system that truly does encompass that which relate to societal circumstances and conditions beyond what is occurring in the clinician's office. So in terms of the feedback, you've seen this slide to some degree already. You've seen that we have gone through a variety of public input processes, interacted with a variety of committees, including the Health Equity Committee, to get feedback on some of the strategies and policy options that have been developed early on in this process. So this just gives you a sense of who has been involved. And there's also more work to be done in terms of greater integrating feedback from populations of people that have been historically disenfranchised and marginalized. And so I'm very pleased to say that work is being fully embraced by this process, and we're moving into a next phase of this work. So in terms of having those interactions, I think it's important to note some of the key themes that we're seeing around what is being said, what's being responded to, where there seems to be energy within not only various committees, but also the community in and of itself. And one of the things that we can just underscore and affirm without hesitation is that the social determinants of health and health equity are affirmed to be, acknowledged to be, and affirmed to be a critical area for CCO 2.0 and an absolute necessity, an absolute necessary area of focus. Within that, there's been some interesting comments that seem to align pretty well with sort of where we're headed, but then some very good, of course, vetting and adjusting and realigning along the way. I think it's important to note that the desire to have a standard definition for what we mean when we say social determinants of health is very, very important. That's a very broad field. There's education, there's housing, there's just so many areas that can become quite overwhelming. So when we talk about social determinants of health, where is it that we want to focus. What do we mean by that, first of all, and where is it that we want to focus? And the Medicaid Advisory Committee has provided an excellent foundation for that definition. There's also been some excellent feedback as well on reinforcing the resiliency of communities and investing in communities and leveraging community efforts. And in health equity and inclusion work, this work cannot happen in a vacuum. The people that are most impacted, the communities that are most impacted, need to have the loudest voice at the table. Need to be the voice that's most heard in this. And so over and over again, we're hearing the appreciation of that interaction, and that funding to community partners is going to be paramount in CCO 2.0 being successful. Within that, community advisory councils have been called out as being absolutely critical, and the whole idea of further diversifying those councils is important. And also maintaining a strong public health system. So this does not happen, CCO 2.0 and public health do not happen separate from each other. We've got to connect all those elements. And finally, I'm really pleased to say that because the Office of Equity and Inclusion is one of the primary drivers behind the Traditional Health Worker Commission and Program, we're really pleased that that work and those recommendations that came forward from the Traditional Health Worker Commission are have received some of the strongest support and backup from the broader community. The one area that I want to add is that an area that we have, not add, but an area that, I'm still on this slide, sorry. The whole idea of metrics, we've talked about health equity metrics and health policy metrics and how that seems to be sort of elusive to us. And that seems to be somewhat elusive to the broader community and to people that we've interacted with around this. But what I'm happy to say is that we do have a health equity metrics committee, subcommittee that's forming, that will include the health equity committee chairs, that will include people from health policy and analytics, including health analytics and the work of John Collins' team, as well as members from some metrics teams that are already in place, and the Office of Equity and Inclusion. So we're trying to get the best brains around this, trying to intersect the discipline of data analytics and data collection with the discipline of equity and inclusion, because those, once again, also cannot happen separate from one another. So that work is occurring. And then finally, I will say on this one note regarding metrics, I've been interacting with Dr. John McConnell and Ronnie George at OHSU, and they have said that they are actually working on the next rendition of some of the studies that they've been doing. You did hear from John McConnell at one point in time in the last few months. And one of those studies is I hope you can appreciate this, is assessing how CCOs are doing in relationship to each other. And they're doing that as an independent body, not as a body of the Oregon Health Authority. So we'll get an independent read on that. And hopefully we'll have a summary in the next couple of weeks to see where that's headed. And that body of work will be very helpful in moving forward with our CCO 2.0 work. So I think I've got just one more thing to add before I turn it over to Chris DeMars, and that is an interesting little sideline here is that housing housing services and supports has really emerged as one of the priorities relating to the social determinants of health. And so that seems to be over and over again information that we're getting from a variety of different groups. And so we would like to bring forward housing as a proposing that for consideration as a statewide priority related to social determinants of health and health equity. And I will just add in closing, before I turn it over to Chris, that this is very much in alignment with work of the Regional Health Equity Coalitions that Office of Equity and Inclusion has been managing for several years. Also a 2014 report that was done by the predecessor to the Health Equity Committee, the Health Equity Policy Committee, did a report, what they call it's a Delphi report, and housing came up as after healthcare access as the next most important social determinant of health. So there's some alignment here that we're seeing, and the community, this is not lost on the community. The community has brought this information forward, and it's very much consistent and a very wonderful opportunity to align previous work done by the Oregon Health Authority and moving that forward to what we're seeing as an opportunity to make a real difference in the lives of individuals and communities that are most impacted by the social determinants of health and are suffering the greatest health disparities and health inequities. So on that note, I will turn it over to Chris to cover the next few slides, and appreciate your time. Also, if you have any questions before we move forward, happy to address those as well. Thank you.
Thanks, Leanne. So now we want to dive more deeply into the 9 policy options and various strategies we've explored over the past several months. These strategies look at social determinants of health and health equity outcomes at the member, organization, and community levels. Some examples of the range of approaches that you'll see are supporting member health through social determinants of health and health equity factors in the community, such as housing or food security, insecurity, building CCO and community partner infrastructure to provide the support, improving CCOs and providers' cultural responsiveness, and increasing use of traditional health workers. So in the next few slides, you're going to see an example, kind of case study or story of how social determinants of health and health equity issues might show up in a clinical setting. And then I'll show a few slides that connect our proposed policy options and strategies with this story. So this is a story of Sarah, and as Leanne alluded to, it's from an actual clinical case study. I want to point out Sarah was not an OHP member, but much of her background and the clinical details of the study or in the story are real. We're going to be looking at the potential CCO 2.0 policy options and strategies. You have in a separate sheet in front of you. It was, I think, right behind the committee reports, if you want to allude to it. And it says, I think, proposed policy options. So we're going to look at how Sarah's care might look today and how it might look in the future, given the CCO policy options that better address social determinants of health and health equity. And before I dive into the story, I just want to point out that we're not making a judgment about the quality of care that Sarah receives in the current environment. We're really just reflecting on systemic gaps in the support she receives related to lack of support for social determinants of health and health equity. So Sarah, for the purposes of today's story, is an Oregon Health Plan member enrolled in a CCO. She's 35 years old, Hispanic woman in her 5th pregnancy. She lives in rural Oregon and works seasonally at a packing house, and she's getting prenatal care at a local clinic. So this slide shows how Sarah's pregnancy might advance under the current system. Her pregnancy has various complications, especially since she started prenatal care late at 24 weeks, although she's still getting very thoughtful, well-intentioned care at her local clinic. However, there are gaps in her care related to lack of culturally appropriate care and social determinants of health and health equity factors that aren't being addressed. For example, the clinic doesn't know that Sarah is food insecure and is experiencing housing instability. The family lives with Sarah's sister because they recently lost their housing. Sarah was diagnosed with gestational diabetes and referred to a nutrition program, but that program has offered some foods that are foreign to Sarah, and she's not kind of comfortable adding them to her diet. Her husband has been working fewer hours because he needs to care for their other children, and Sarah needs dental care during her pregnancy, but access is limited in her rural community. So looking at Sarah's potential outcomes under this system that I just described, she struggles to control her diet. As I mentioned, the nutrition program she's referred to is not culturally responsive. Because she can't get access to dental care during her pregnancy, which is a really critical time for dental care, her dental health gets worse. Women with gestational diabetes, especially if it's poorly controlled, are more at risk for developing preeclampsia, and this happens to Sarah. So she has to deliver her baby preterm in order to protect her and her baby's health, and the delivery is via C-section. Postpartum, Sarah continues to experience social determinants of health-related challenges with food insecurity and housing. The chaos and stress impacts her health, causes her to miss her 6-week follow-up appointment. She ends up getting an infection, which may have worsened due to the stress and poor diet. She readmitted to the hospital because of the infection. And we don't know what caused the infection, but as I mentioned, it may have been caused by social determinants of health and health equity factors playing a role. So now we're going to fast forward to kind of the same story, but looking at it through the lens of system changes that hopefully will be put into place per the CCO 2.0 recommendations for social determinants of health and health equity. These have advanced to increased capacity at the local clinic level, like Sarah's, to identify and address social determinants of health and health equity factors and provide culturally responsive care. So, for example, Sarah meets a bicultural community health worker at a community event, and she starts prenatal care early. The clinic screens her for social determinants of health factors, which identify that she's has housing instability, is food insecure, and has child care issues. A community health worker refers her to a housing case manager at a local nonprofit and helps her family find stable housing. She's diagnosed with gestational diabetes and referred to a culturally specific Veggie RX program that helps her enroll in SNAP, which allows her to connect with a local health department that signs her up for their Double Up Food Bucks program, which gives her, which matches up to $10 at a new local farmers market where she can get fruits and vegetables. Sarah's husband can work full-time since there's the local early learning hub has connected Sarah's family with a Head Start program that offers after-school care program as well and includes transportation. And then Sarah can also receive dental care through a local hygienist that is practicing teledentistry with a dentist in another community. So the system changes put in place within the next 5 years might lead to better outcomes for Sarah. So because she's has access to culturally responsive Veggie RX program, she now has more fruits and vegetables and culturally appropriate recipes. She's also better able to manage her gestational diabetes. Because she gets dental care through teledentistry, she has better control of her periodontal health. She has better control of her gestational diabetes. She does not develop preeclampsia and develops her baby at term. She still has to have a C-section because of her baby's position. However, postpartum, Sarah has a healthier diet, and her family gets to move into stable housing. And perhaps because of the reduced stress and chaos in her life, she heals well from the surgery. She doesn't miss her 6-week follow-up appointment and is not readmitted into the hospital. So how did we get here? There are various changes related to infrastructure at the CCO, clinic, and community levels to address the social determinants of health and health equity factors that Sarah addressed that have resulted in improvements in her individual care. There are also improvements at the community level that we don't see in Sarah's individual care, but had a positive impact. For example, the CCO is now spending more on programs that support social determinants of health and health equity related to housing and food. There's a more empowered community advisory council within the CCO, and there's a shared community health assessment, community health improvement plan at the local level. The next few slides, I'll show how certain policy strategies related to the social determinants of health and health equity might build the infrastructure that resulted in this more holistic and effective care for Sarah. So on the left-hand side of this slide and the following two slides, you'll see the policy options, and on the right-hand side are the specific strategies that we're proposing. So this slide kind of gets at the first strategy, which is the CCO has received seed money from OHA for a 2-year period to meet an ongoing requirement that was put in place by House Bill 4018 that was passed earlier this year to spend a portion of their savings on addressing social determinants of health and health disparities. The CCO uses seed money for three separate purposes. One is to increase infrastructure for local clinics to screen and refer for social determinants of health issues. The second was to fund a housing case manager, which is in line with a statewide priority on housing, which ultimately helps Sarah's family find housing. And then third, the CCO used the seed money to fund local organizations that increased Sarah's access to healthy food and started a farmer's market in her area where Sarah used the Double Up Food Bucks money match that she got from the local health department. So all of this work stemmed from the CCO's focus on food insecurity and obesity, which was identified in their shared community health assessment, community health improvement plan that was also aligned with the state's health improvement plan. There are key community partners involved in shaping the CHA and the CHIP, And then finally, I'll mention also one of our strategies is a new state definition on a common understanding of social determinants of health and health equity factors. And it allowed the CCO to really focus on what qualified for the spending requirement related to the seed money in the House Bill 4018, and it led to investments in housing and food insecurity instead of more downstream investments, such as perhaps gym shoes or a gym membership. So going back to Sarah's story, she, as you heard, she received more culturally responsive care in 2025 and was able to increase her immediate and ongoing access to healthy foods. This is made possible through the CCOs using its health-related services to fund the Veggie RX program for Sarah individually, and then to also fund the Double Up Food Bucks program at the community level. And this second program, the community level program, is in line with their health-related services community benefit initiative, and the CCO's Community Advisory Council has been involved in making those decisions, and those are in line with the Community Health Improvement Plan priorities. The Community Advisory Council also had increased diversity and participation from social determinants of health and health equity partners because of two new requirements. The first is that CCO membership needs to align with the demographics of Medicaid members and also include representatives that align with our Community Health Improvement Plan priorities. For example, if food insecurity is a priority in the Community Health Improvement Plan, then the CCO would want to involve a food bank representative on their Community Advisory Council. The Community Advisory Council is also more engaged with the CCO board and with decision-making because of a new requirement that 2 CAC members sit on the CCO board. Currently, it's set at 1 CAC member. And then finally, the CCO has dedicated more resources for health equity activities, including having a health equity plan, and that includes cultural responsiveness education for providers. So all of these changes have led to the CCOs investing in programs and that are more aligned with CCO member needs. And then the final slide that reviews our policy options and strategies. So going back to this story, Sarah went from starting her prenatal care late to connecting with a clinic earlier through the help of a community health worker. This was made possible due to increased resources for community health workers and other types of traditional health workers, due to the CCO establishing a traditional health worker utilization plan, a sustainable payment system, and process for traditional health workers, and using a traditional health worker liaison. Sarah went from having childcare challenges to connecting with a local health Head Start program that offered aftercare and transportation, and this was made possible because the CCO, the Early Learning Hub that connected Sarah to this program, had increased capacity because of a new metric, a new CCO incentive metric that was put in place related to kindergarten readiness. It meant the CCO focused more intentionally on establishing a closer partnership with its Early Learning Hub, and it rewarded the Early Learning Hub for helping the CCO achieve their metric target. And this allowed the Early Learning Hub to expand its work, and Sarah's family was able to receive services. And then finally in the story, Sarah went from not getting dental care due to access issues to having access to dental care because of the teledentistry program in her community. So in summary, this slide shows all of the policy options on the right-hand side, and then there are specific strategies that I've gone over that are within these policy options. We just want to point out that these options are in general supported by research and public input, and we feel they work as a package, that they're complementary. So with that, happy to answer any questions, take your reactions, and if there's any kind of prioritization that you want to point out at this time.
Go ahead, John.
So I think that was great. I think it would enhance the presentation if you could identify any CCO who is doing, who has done some of this, and so is an early adopter, has succeeded to, any degree. The other issue, I meant to mention at the first presentation, I must admit I'm getting concerned that anything involving fee-for-service is going to eventually be a mess. As I think fee-for-service just doesn't work. And so I think as you propose that traditional health workers be integrated, that, various trying to figure out a mechanism to pay for that that's not fee-for-service, because it's the administrative costs of fee-for-service, and the incentives are just wrong eventually. So, I mean, I would be interested when the finance people start to get involved and look at these, and well, how would we pay for those? I just am so worried about a world of fee-for-service that just can't work.
So just two quick comments. There are many CCOs that are adopting many of these strategies. So great point, and we can highlight some of those. And with regard to fee-for-service and value-based payment, we'll have a bunch of time this afternoon to talk about it. But it's absolutely, it fits, and we're thinking about that. So thanks for bringing that up.
Thank you, Leanne and Chris. It's an excellent approach. And for us to understand what CCO 2.0 could achieve and the policies to get there. And I really appreciate your emphasis on community partners because, as you know so well, the social determinants of health operate due to social, economic, and environmental factors that occur in the community rather than the clinic. And those community partners will be essential to pull the levers to change these forces. But I also encourage you to push a little bit farther and to move, your example is based on a CCO member. And those health inequities occur long before someone ever becomes a member. And push you farther from thinking about the members in the CCO and the covered lives to the population. And I think this is important to improve upstream causes of social determinants of health inequity because these occur at the population level. And community partners are very helpful, but I want to avoid an unintended consequence where the community partner is reimbursed to find housing for the CCO member and pushes two people who aren't CCO members out of housing, and creating this zero-sum game where there's perverse incentive to prioritize housing for those who got into a CCO and the people who don't get into CCO because of greater health inequities don't have access to. And the only way I can think about covering health at the population, and it was mentioned, you included it, is through the local health authorities, because their mandate is really to cover a population. This also pushes them into a new comfort, maybe a new zone to think about more than just disease surveillance and traditional activities of local health authority. But I think their charge to think about a population is really important. We heard from Bruce Thompson examples during the public testimony about examples where there's duplicate community health assessment plans and duplicate community health improvement plans between the CCO and local health authority. I think that's really very important to reconcile and to remove those redundancies, such that we can then, rather than say we're going to improve health at the population members and ignore everyone else, say get out of the zero-sum game. How do we improve health of the population? And of course, the CCO is going to say, well, we're not comfortable with that because we're responsible for member lives. But through this partnership with community health organizations and local health authorities, we create a frame shift to what are the health outcomes at the population level.
And if I could just point out that one of our strategies is for a unified community health assessment at the local level,
Great.
and when possible, one community health improvement plan at the local level. And the reason that may not always be possible is that there are hospitals that CCOs might contract with different hospitals, and they're on different timelines, and may not be able to kind of come up with one community health improvement plan. But when possible.
But the local health authority could.
Oh, yes.
Yeah,
I mean,
yeah.
yes, that's true. And I don't know, Amanda, if you have anything more to say about that. But the local health department and the CCO definitely. It's just we also are looking at folding in the hospitals too.
Yeah.
And so, yeah.
So one of the things is, the comment I have is the same one that I made to behavioral health, is understanding what kind of changes have to be made. Are these contracts or legislative? So recently, in a conversation, there was some discussion about funding from the CCO for social determinants of health, and one of the barriers that was brought up, which I don't know if this is a realistic barrier or not, is that there's a mandate that CCO spend a certain percentage of their funding on medical services, and that some of these items that you have listed here don't fit under that umbrella, and therefore there's not a clear pot of money of where that money comes from. And so I don't know if that is true, whether a redefining of what, instead of medical services, health services needs to occur so that health services includes some of this that you're talking about. So they, in order to be able to support some of these programs, they literally have to take money over here to move over here, and they have to make sure they're maintaining a stream to medical services, which sounds like to me is being defined as traditional types of services, the small piece of the pie that's on this pie chart. So I don't know if that's something you've looked at, or if it's, like I said, this was in a conversation, so.
So health-related services, which can be used to fund some, provide supports around social determinants of health and health equity, they actually count for the medical portion of the medical loss ratio. So in the conversation you had, they would actually count toward medical.
So do you feel like there's maybe a lack of understanding of that within the CCOs about that definition and what's covered and not covered in their reports?
I think maybe, yes.
Okay.
I will also say that with regard to, and there are people in this room that can speak to this much better than I can in terms of rate development. With regard to rates, the person you were talking to may have been reflecting on that, and health-related services spending is counted in the then it's called the non-benefit load, so kind of the non-medical side of the rates, but they're still, the spending is still considered for rate development. So I think there is a communication issue here to a degree, and we're trying to address that.
Great.
And can I just add on?
Please.
So, I mean, that was basically as far as we got with CMS with our last waivers. They allowed us to, we require CCOs to spend a portion of their budget on members, and we're allowed to count health-related services, and that it's a new thing. It's within our new waiver, and so it's a new definition. It includes both what we used to call flexible services, which are, individual things for members, as well as community investments. But we are not allowed to count it in terms of what we consider medical services in terms of how we build CCO rates. Ultimately, we'd love to be able to get there with CMS. That's a longer-term strategy. But I think what Chris is proposing in some of this is us doing a better job of trying to translate where the opportunities are, exactly how that relates to rates, and make sure we're connecting the dots for CCOs and explaining, where they can make investments and how they can make investments and how that's going to show up in next year's rates.
And can I just add one more piece, that the health-related services policy strategies are one area where the CCOs can use their funds to cover social determinants of health-related activities, and then the social determinants of health spending requirements really brings out another opportunity around the savings that CCOs are garnering related to reserves or net income or other types of savings that are treated a little bit differently, but can be another area to use social determinants of health spending.
So one of the strategies we'll hear in the costs portion later this afternoon is developing a kind of efficiency metric where if the CCO is making investments that otherwise might not show up in next year's rates but are clearly improving outcomes, that we find some way to offset that.
Okay, great, thank you.
I think my question or comments are probably in the next phase of iteration around the social determinants, but I'll say it now. And I may be channeling Joe Robertson and some of his previous comments with this board about how concerning it may be to invest in this particular area. In the part of, the housing crisis is so significant, the gap is so tremendous, that how we set framework and expectations in terms of direct services. And by the way, I say this with my background as a former public health nurse, so that by no means am I saying anything that I somehow discount or undervalue this important and really critical work. I think the devil is in the how, and so how do we set CCOs and their investment priorities such that they're both paying attention to the population-based measures I think that we were referencing earlier in systems alignment, and in the policies that, help us enable better housing situations for the constituents in our communities, as well as where you were just talking about how to rates and member services from a direct service or a housing case manager help support. So however we get into this next layer of detail, I'm hoping that there's a strong balance between both of those frames, the direct service piece as well as the systems piece.
Yeah, and I think I agree with that, and I repeat, that is the intention. But if we create incentives for alignment, we get healthcare systems talking with housing authorities, and it's an incentive to bring the health systems to the table to engage productively with housing and education being, I think there's 3 buckets. There's health systems, there's housing and education. That's a big, I think are big levers. But yes, we can't, health systems by themselves won't solve this problem. But if we can't create financial incentives for them to engage and align with these other sectors, I think they'll engage and align more productively. So you create education incentives and health authority incentives as well, but that's a different committee.
I think this does bring up a generic issue. I know when I've listened to the CCO meetings, albeit by phone the last time, far and away the most common comment from them is, well, how are you going to build this into our rates? How are you going to add this to our rates? As they probably should from a negotiating point of view, see everything as an add. Well, wait a minute, don't we think that this is going to reduce their costs? Well, in what time frame is it going to reduce their costs? And, so what things are this will reduce your costs in 1 year, 3 years, 5 years, versus this will increase your costs for the foreseeable future. In another life, we did that with the drug companies, who all have these models. They have these economic models. And of course, those models, it's key the assumptions that are built into those. So I think this is an important conversation as we look at adding this or that. Well, where will this fit in terms of a rate and what's its return on, a reasonable return on investment timeline, that kind of thing.
This is good conversation. I think that's helpful for me as I think about this. I'm struck by, like, there's 3 parts to the end goal, what we don't call the triple aim anymore, but then we do. Cost is one of them, but then population health and quality of care are the other 2 pieces. And I think one of the things we probably need to get clear about is what our expectations are on the role of CCOs in each of those buckets, because I don't think it's just about containing costs, nor is it just about member health. I think there really is this bigger piece around how we're transforming the health of Oregonians and how CCOs are a fundamental actor in that process. And so it would be really helpful. This is one of those spaces where that can become much more visible, both what the opportunities are and what the challenges are. And I'd love to be able to see that a little bit more clearly. I recognize and understand that in order to make an impact on social determinants of health and to really start to influence and impact health inequities, resources are going to have to come from a number of different places. I want to know more about which actors need to engage in what ways. I think there's opportunity with other state departments, whether it's housing, whether it's education. Early Learning Division is a part of education, to really put some pressure on in a positive way some of those other systems. I think there's also, as I understand it, some alignment opportunities as they are also thinking about what the goals are in the next 4 to 5 and 6 years. So I'm looking for where we can take advantage of those and where the policy board is in a good position to have some of those conversations with like policy bodies and with the governor and with those other departments. I'm really interested in within the bucket of resources that we have, how to maximize the use of health-related services through the new negotiated relationship with CMS about that, and where that's about kind of ramping up our utilization of that capacity we currently have versus where we come up against some of those thresholds or issues that were described in terms of the rate making process and otherwise. But it seems to me like part of what I keep hearing is health-related services is this huge bucket we have the opportunity to take advantage of, and we're not yet, and that's fine. But just what do we think that looks like? And where do we, to Brenda's point earlier about the difference between kind of pushing just enough so that we're really incenting change and pushing so hard that we've stressed out the system and we actually have negative impacts. This feels like I don't know where that space is there, but we're talking about wanting to go somewhere here and not getting too far out of whack there. So I'm really interested in figuring that out. I believe in terms of I believe we need to incentivize and measure progress at a CCO level and a state level around social determinants of health and health equity. And I don't want to get stuck in a metrics, quality metrics bucket that prohibits our ability to actually have that conversation. So whatever it takes for us to ensure that at this level that we're really clear, we have to incentivize, we have to be able to measure progress at the local level and at the state level, and that we need the state actors to figure out how to make that happen. That needs to happen. So if that looks like new and different kinds of metrics, if that looks like it can fit in certain ways, great. But I'm not interested in running into roadblocks there. I'm interested in figuring out how we can really get at that. So I appreciate that it's here, and I want to see what kind of detail is underneath that in terms of opportunity. And then the last piece that I would just raise at this point is two pieces. One, I also really appreciate that the traditional health worker recommendations are effectively incorporated in different parts of this, and I'll really be looking for that, because I think as we've gone out and talked to folks in the community, that we hear that time and time and time again, that in particular for those who are farthest from the outcomes that we want to see right now, that the people who they're most likely to engage with are people who understand their lived experience and who are their peers, whether that's DV specialists in one community, whether that's community health workers in another, is less important, but they all fit in this frame, and I'm interested in how we can really maximize the use there. My sense is this is one of those places where we've tried to do some work at a state level and where there isn't the same sort of uptake in terms of utilization in the CCOs, and I'm interested in that gap and what's causing that and how we can impact that. And then the last piece I would say is I want to know how in this kind of yellow frame about strengthening partnerships and meaningful engagement, I want to know how we can get really clear about our expectation of ways that local communities are aligning their efforts and how we're creating spaces for other systems to come to the table, and then how consumer voices are and individuals are authentically engaged in governance. And I'd say that very explicitly. I don't believe that we're going to make change until we get a critical mass of leaders who have lived experience that understands on a daily basis what health inequities look like, and is going to bring a level of urgency to change at a local level. So I want to see in our CCOs, and I know some of that may require that we continue to engage the legislature in that process, how we incorporate those perspectives effectively into leadership. So those are some of the things that I know the policy options are alluding to, and I'm excited to see how they surface in more detail at the next levels. And I think I don't know that I prioritized across those, but those are all really important.
Could you just tag on a little bit on some of the comments around kind of what that right balance is on social determinants? I think the types of feedback they don't have to answer today that will be helpful for us is, should we be setting a priority of housing in this next, and not saying CCOs are the only responsible party there, but should we be even setting that type of expectation, or should we be fully leaving it to the community? I think if we set that type of expectation, I think there is a way to design the community health assessments and community health improvement plans in a way that brings other partners to the table. Just an example, had a good conversation with Oregon Department of Housing and Community Services this week. Coincidentally, their 5-year plans for housing align perfectly with our 5-year plan for CCO 2.0. And so, more conversations to be had there, but the initial conversation was, how do we sort of leverage both resources? How do we leverage their investments in brick and mortar with the ability of CCOs to bring supported housing and other types of things to the table, and what local partners could help participate in that. So just throwing that out there is, I think there is a way to strike that that balance, and we'll be looking to you on how hard, we push or what expectations we set for CCOs.
Let me respond to that in terms of delineating and apportioning responsibility. I think it's a fair discussion, debate what CCOs can do. Clearly, they can't solve these broad social forces by themselves. There are some important things that can be done, and that's really important for us to discuss and include in the contracts. So the CCOs aren't responsible for solving social forces. I don't think that Oregon Health Authority, however, is responsible for promoting the health of Oregon. And the question, and I think it's the Oregon Health Authority's responsibility to say, how do we put the pieces of the puzzle together? CCOs are an important piece. What are the other pieces of the puzzle? Housing, to the extent it impacts health, education to the extent it impacts health, and other components, components for the promotion of health. And so that responsibility ultimately lies with Oregon Health Authority. CCOs are a tool, housing is a tool, education is a tool, and for you to do the creative thinking about how to bridge these partnerships and incentivize these partnerships is really important.
I think also there's an opportunity when we talk about, for example, traditional health workers, that is where the clinical setting meets the social determinants of health. And so to invest in those types of interventions where there can be an impact at the clinical level, but it's community-based and broad-based. It doesn't take CCO 2.0 off track in any way, shape, or form, but it's looking for the areas where there can be enhancements regarding that community-based health-related emphasis.
I think my reaction to your comments, Jeremy, are push hard and you kind of go big or go home. This is an opportunity for us, I think, when I look at the window of things that were missed in the last procurement process, this is space that was sort of cursory and process improvement steps and not really material movement, I think, significantly. And I mean that in the way both on the cultural competency parts of the conversation as much as the really specific projects around social determinants. I think that the press I would really hold to, and I think this is to your point, Chris, around if we require combined community health assessments, but we sort of lay off the tension on a community health improvement, then we won't know if the specific community says housing is their priority. And if we allow some slack that we don't require a combined community health improvement project or improvement plan itself, I don't think we'll know specifically if that's the right tack to take. So that would be one nuance to the question of, is it this board's responsibility to say, yes, housing is it? Because then we get in this kind of, is it housing, is it food insecurity, is it, those debates that I've heard about. And I don't know the answer to that, but I think the pathway through the health assessment and the improvement plan is actually feels more respectful to the community.
Yeah, and I think if the priority of the board is to align chips, then we can go back and figure out what tools we have to get there.
Yeah.
And across all these domains, education, housing, health, criminal justice, there are equity and inclusion components all the way across, so possibly is that the driver here? Because we don't exist, equity and inclusion doesn't exist in one bucket, it exists across disciplines.
I think the other thing that I would say to this conversation, which gets a little bit at a point you made earlier, Jeremy, I actually think that it would be most helpful with these different, at the point in the process we are now, to understand what kind of very stressful policy recommendations mean to the system. So to go big or go home, I want to see that on each front. So one of those is, what if we said housing is the social determinant we want all communities across the state to be focused on, figure out how to make it happen? And or what if we said we want to see alignment across the community health improvement process, which includes both the needs assessment and it includes the planning the plan and the development, and then the articulation of how budget and resources align with that plan and where those resources come from. Like, it'd be, because of where we are in the process now, that I think allows for local communities and stakeholders to give us the most input about what kind of stress that actually does create and what that stress looks like. So I would just encourage staff in a way that I think is not indicative of what kind of state government staff are really often at liberty to do, is to really put out there some kind of bold opportunities, and then part of our job together is to figure out which of those actually make the most sense and to what degree, or where we kind of need to scale back what expectations look like there. That would be really helpful for us. So I'd say, you know, explore both options in a pretty significant way. And I'm really interested to hear what people's feedback is. I would expect that we'll hear local communities saying, why are you telling us what's the biggest issue in our community? And what I want to know then is, so then how are you going to figure out what the significant issue is? And what's the mechanism for ensuring that you're not just going to do that as an assessment, but that you're actually going to tie resources to starting to address that? So that would be great dialogue or discourse on multiple levels.
Thank you.
So I want to just say, one, thank you all for the work you've done. I also want to acknowledge the Medicaid Advisory Committee and the significant amount of work that I think they've done. And just say out loud, I don't think we talked about it as much, but for me, the kind of definitional stuff is a no-brainer, and it's really exciting to see that in here, and I think that's a key part of what they've recommended, along with other recommendations. I also want to acknowledge the Health Equity Committee that has been standing up and at the same time saying, how do we provide effective guidance and input here to a process that was already underway. So I know there are others, but just I appreciate that that's happening. And then I want to just say that I think the social determinants of health work group that's come together inside the department is really exciting in terms of starting to dig into some of these specific questions and issues. And it feels like we're going from a place where it's kind of a boutique concept, wouldn't it be interesting and cool if we could, to a place where we're really trying to embed it at a central level in the expectations and the opportunities that the coordinated care model creates. So thanks for that.
Thank you.
Thank you very much.
Thank you.
So we're going to take a lunch break, and we're running a little bit behind. So by lunch break, that does not mean that we're all going to go as board members and find our lunch somewhere. It means, and then sit down and eat it. It means we're going to go find our lunch, which will be very easy for us to find because it's very close to us. And then we're going to sit right back down, and we're going to keep going so that we can keep on schedule. So let's take 5 minutes to grab our lunches, sit back down, and we'll get going.
Make sure you come back.